Good evening, everyone. On behalf of NNF Karnataka and Genworks and Natus, I would like to give a warm welcome to all the participants, attendees, and this is going to be interesting. This is the 3-episode web series which we are starting, and we already have so many participants who have joined from all over India and even outside India as well. Thank you very much for showing your interest in learning and upgrading your knowledge. Today we have got our wonderful speaker, Judy More. On behalf of NNF Karnataka, the entire members of NNF Karnataka, we would like to give a very, very warm welcome, Dr. Judy. Hi, Judy.
Thank you very much.
Please welcome, Judy.
And I would like to give, extend my warm welcome to our panelists who have joined, sparing their time in their busy schedule, and we understand how the situation is across the globe. And in spite of that, you have made some time to teach people. Thank you very much for showing your passion towards teaching. We would like to extend warm welcome on behalf of NNF Karnataka to Dr. Monika, Dr. Neha, Dr. Jafar, Dr. Leslie, Dr. Prathap, and Dr. Amit. I think he'll be joining us soon. And I would like to welcome our moderator for today, myself and Dr. Dinakar will be moderating, sir. Welcome for the session, sir. So now I request Judy to start the session. And before you start the session, I would like to introduce yourself. And we want to hear from your mouth how passionate you are about the amplitude EEG and how passionate you are about the premature brain monitoring to prevent, how beautifully we can prevent the damage to the premature brain with this. So, Judy, over to you.
Thank you so much, Dr. Prashant, for the very kind, warm welcome, and of course the invitation to be part of this series over the next 3 weeks with all of you, examining, the brain, bedside brain monitoring, and the utilisation of aEEG in the neonatal intensive care unit. My name is Judy Moore. I am currently working as Senior International Clinical Support with Natus Medical, specifically focused in neonatal brain and brain injury. In my other life, as I like to call it, I'm also an advanced neonatal nurse practitioner from the UK, as you can probably tell by my very British accent. So this is where I reside. I always introduce these sessions when we talk about the brain and brain monitoring, that I feel like I've grown up with aEEG, and in fact this year I celebrate 30 years in neonatology, and it is a celebration to be able to be part of this community of everybody who's so passionate about the neonate and giving them the best start in life. So with no further ado, I will get started. So we're going to talk today, as the first part of this series, a little bit more about the basics of bedside brain monitoring, but also about the wider population who can be monitored outside of that group that we know about already, which is the infants with hypoxic ischemic encephalopathy. So let's start off and think about how the newborn brain is currently assessed. What is it that we do today if we haven't got objective monitoring technology to assess the newborn brain? Well, clearly the first step is the clinical assessment. And with our clinical assessment, we're examining the state, the activity, the reflexes, the tone of the infant. But we have to remember as well that these clinical assessments that we make of these infants really can be influenced by any sedative or paralytic agents that we might actually give to the infants. So, they can be subjective, and they can be influenced by the level of the person who's actually, performing that examination as well. The second thing that we can do to assess the neonatal brain is the multi-channel EEG. And we all know that multi-channel EEG is the gold standard in assessing brain activity, But we also know that its use is often limited to office hours or to the response of on-call personnel, and it really does require expert application and expert interpretation. And very often we usually only get a short snapshot in time. You know, we might get the neuro guys to come over to us. We might get 45, 60 minutes, best case scenario of a multi-channel EEG, and we might miss that critical item we're looking for example, seizure activity during that period of time. So we're not getting long-term monitoring with multi-channel EEG, but it is still the gold standard for diagnosis. And then finally, of course, we've got our MRI, CT scans, ultrasound imaging, which clearly give us very good structural evaluation. But again, we know with MRIs and CTs, this often requires the transportation of these acutely sick kids, in many cases, off the neonatal intensive care unit. They do require expert interpretation, and in many situations, there's limited availability. They can be expensive tests to do. So bearing all of that in mind, what else can we do and what else can we utilize at the bedside? And this is really where aEEG comes into its format. So aEEG, it's a 1, 2 or 3 channel bedside brain monitor. It's a basic neurological function trending tool. So it gives us this long-term monitoring capability, and it's used to measure the global electrocortical activity or specific site brain activity. We can look individually at the left or the right side of the brain. An important thing to remember about aEEG is it's a tool that was developed by neonatologists for neonatologists, which is very different to conventional EEG, which was clearly developed by neurologists and neurophysiologists for use and interpretation by that group. So I like to describe aEEG as this complementary tool in everything else that we do for these sick kids that really allows us to quickly obtain information regarding the baby's neurological status, because it's so easy to apply. You know, we can get these electrodes on and be monitoring within minutes, and we can get that vital neurological information we want at the point of care. So bearing that in mind, I want us to think just a little bit about the monitoring devices we use in the NICU today. And we're monitoring lots of things on these kids all of the time. So if you think about any baby who's admitted to the intensive care unit, they'll have lots of things monitored: blood pressure, heart rate, temperature, oxygen saturations, maybe end-tidal CO2, respiratory rate. We are constantly monitoring these infants, and if I was in a live audience, I would actually ask you guys, why are you monitoring these kids? And the answer really is because we want to look at system function and stability, and we also want to know that any of the treatments that we're giving or changes in management are having a positive effect. And we can see that on monitors, can't we? We can see whether if we've given inotropes, it has an effect on blood pressure. We can see if we've changed the ventilation, it has an effect on oxygenation and carbon dioxide. So when we think about we're monitoring all of these things because we're monitoring all of these systems, it really begs the question then, well, what about the brain? Why wouldn't we routinely monitor the brain? Because surely the brain is the vital organ. The brain is the long-term future of these children. So monitoring of the brain is really important. And I often talk to nurses about this. Now, why wouldn't you monitor the brain? And when you talk to nurses about monitoring the brain, you generally get a look of fear across the face of the nurse. And you get this, help, I can't do brain monitoring, because they're thinking of these babies that are having these full and conventional EEGs, and that it's going to be very, very difficult to manage. And of course, this isn't what aEEG is all about. So I like to put aEEG monitoring in context with the other monitoring tools that we have in the NICU. And if we take this first baby who will appear on your screen in a moment, this baby is clearly having ECG monitoring, and we just do it routinely. Babies get admitted, we apply the ECG electrodes, and by doing that we get a very simple one-channel pattern on our bedside physiological monitors, which, as experienced neonatal personnel, we learn very quickly to recognize if there is a problem with the ECG, and then we can intervene. And that's absolutely no different to brain monitoring. It's just with brain monitoring, we're putting the electrodes somewhere else. Now we're putting the electrodes on babies' heads. And again, we're just getting a simple pattern on a bedside monitor that is very easy to learn to interpret if it's normal, moderately abnormal, or severely abnormal. So again, I just want to put this into context. I want to imagine this as a routine monitor in the NICU. So if we take the bedside heart rate monitoring and we put it beside bedside brain monitoring. Again, with the heart rate monitoring, we start with these 3 leads of ECG, and they give us this simple pattern on the bedside monitor. With the brain monitoring, we use either 3 or 5 leads of aEEG, dependent on how many channels we want to see. And again, then we very easily see this pattern on the bedside brain monitor. And why do we do that again? The importance is it's alerting us to a problem. And if I've applied my ECG electrodes, I find a problem, I'm probably going to call the cardiologist. And the cardiologist is going to come along and do his full cardiac study, which, as a cardiologist, he's trained to interpret and provide me with a diagnosis. It's exactly the same with aEEG, but instead of calling a cardiologist, this time I'm clearly going to call the neurologist if I find a problem, usually seizures, and I'm going to ask him to come and do his consultation, his multi-channel EEG, which again, as a neurologist, he's trained to interpret and provide me with more information. And then, of course, that gives us the information to go on to decide what else is it that we need to do for these infants. But I think one of the biggest things about aEEG is the bottom section there, which is prognosis. We know that looking at that aEEG over time in those early days is really strong in helping us think about the prognosis of these infants. So let's have a think about what it is we want to know when we monitor the brain with aEEG. Well, there's quite a bit of information that can be gained from aEEG monitoring. For example, aEEG can help the clinician understand if there's been a cerebral injury, help us understand the severity of that injury, and because we monitor it continuously, it helps us to understand any changes that are occurring over time. Is this baby's brain function improving? Is it worsening? Is it staying the same? Because we're monitoring continuously, we have that information directly at the bedside with us. The next thing it can really help us in identifying, and I'm going to talk a little bit more about this later, is the patient having seizures? And if so, what is causing the seizures? It can help us to identify why that infant's having seizures, what other investigations we may need to do. And again, because we're monitoring continuously, we can see, are these seizures occurring more frequently? Are they longer or shorter in duration? Are they responding to the medical therapy that we're actually providing? Is there an electromechanical dissociation after medication? So having this monitor on all of the time provides us with this really objective information. So this is the time that I would like the audience to be interactive, and we're going to launch a few of these polling questions as we go through. So I am going to ask you guys out there today, which infants are you currently monitoring with aEEG. So is it those who are suspected to be at risk of HIE and you're cooling them? Anybody monitoring preterm infants, those with intraventricular hemorrhages, periventricular leukomalacia, post-hemorrhagic ventricular dilatation? Anybody monitoring cardiac or surgical infants, the metabolic kids, congenital malformations? Or if you're not monitoring currently, then tick not monitoring, okay? So let's for the sake of time, I'm going to close that poll. I'm going to share those results with you all so you can see what the general consensus is from everybody. So we can see the biggest majority, and this is not unusual, the biggest majority of people are monitoring those babies that you suspect to be at risk of hypoxic ischemic encephalopathy or that you're cooling them. And that's great. And please carry on. And then there's a small percentage of people monitoring the preterms. We're definitely going to go into depth with that next week in the next part of this series. Nobody's monitoring surgical or cardiac infants. 2% of people metabolic and congenital malformations, and about 38% of people not currently monitoring today. That's just interesting because it's going to help me hopefully lead into my next question, or my next slide, I should say, to look at who is it that can be monitored. What are the clinical applications that we can utilize bedside brain monitoring for? And as 55% of you said you were doing, it's those infants who've experienced this sentinel event during delivery, and they're at risk for hypoxic ischemic encephalopathy. So anybody who's born, who has a low APGAR score, is acidotic, has required artificial ventilation or resuscitation at birth, is floppy, got the poor tone, poor reflexes, absolutely has had a potential hit to their brain and deserves to be monitored. The next group is those babies who are being cooled. So any baby who's receiving hypothermia treatment for HIE, because again, from all of the studies that we read on this, we know that monitoring these infants continuously, not just even during the cooling period, but through rewarming and in the subsequent day or so afterwards, again, it gives us a lot of information prognostically, dependent on how quickly their brain returns to a normal trace or how quickly they achieve sleep-wake cycling again. So it's vitally important to monitor those babies who are actually receiving hypothermia treatment for hypoxic ischemic encephalopathy. Then there's the group of babies who are definitely, or we think are having seizures because they're having movements, physical movements that look like seizures, or questionable seizures. We think they are, but we're not sure. And we know that a large percentage of neonatal seizures are subclinical. So again, it's a vital group to monitor. Anybody you suspect is having seizure activity, to actually monitor them, because we can see that on a trended basis over time. And then the group that I call the unexplained neurological symptoms. So a classic example, full-term baby, normal delivery, goes to the postnatal ward with his mother and starts having dusky episodes and apneas. And, you know, as usual, we investigate them for sepsis and we think it must be an infection, and we swab the mother for group B strep. But actually, a severe apnea in a full-term baby is always abnormal, and one of the causes can actually be seizure activity. The next group is those babies who really are at higher risk for cerebral complications simply because they've generally got circulatory instability. So severe sepsis, the meningitis kids, infants with persistent hypoxia, persistent pulmonary hypertension, meconium aspirations, cardiac malformations, and there's growing body of evidence about monitoring cardiac infants and diaphragmatic hernias. And then there's a whole host of other additional clinical applications where we really know that aEEG can be beneficial for us. And so that might be those babies who we've muscle relaxed because we want to take more control of their ventilation. Now, if we've muscle relaxed them and we've paralyzed them, we can't see any seizure activity. And if they're that sick, that they've required muscle relaxants and ventilation, they might be that sick that they may also seize. So it would definitely be a group to add to the list to consider brain monitoring for. The next group is the preterms, so babies with intraventricular hemorrhages, the extremely low birth weight infants, and again, we'll talk about those next week. Babies with inborn errors of metabolism, I'm going to share a study with you shortly about this group, and dependent on the type of metabolic error that they have, would depend on the percentage of seizures that we actually see in these infants. We know that the babies with neonatal abstinence syndrome also have high percentage of seizure activity. You know, those babies who have alcohol or opiate withdrawal because their mother has abused substance during pregnancy. And they also really struggle with cyclicity. They're not able to organize their brain activity very well at all. Then the babies post-surgery, post-cardiac arrest, and any who may be requiring ECMO or, again, surgery for critical congenital heart disease. So you can see here there's a huge list of infants that can benefit, and we can benefit from seeing their neurological status on the monitor. So I want to move into talk about how aEEG actually works. What is it that we're looking at here? So amplitude integrated, or aEEG, stands for amplitude integrated electroencephalography, and it's 1, 2, or 3 channels of EEG that goes through a number of modifications that I will explain to you in the next couple of slides. That includes, basically, we filter the signal, we try to reduce artifacts, we rectify it, we compress it, and then we map it out in a very slow trended display on the screen. So in basis, aEEG, it's a process of taking the raw EEG, modifying it, and producing a trended pattern that allows us as bedside clinicians to measure and view the microvoltage of the brain over time. Now, in order to achieve this, we clearly need to get the signal from the brain. So we need a channel of EEG, and we require 2 electrodes to create a single channel. And what we're actually doing is we're looking at the electrical voltage difference between 2 electrode sites. And then we're measuring it. Remember, we're measuring brain activity in microvolts, very, very small electrical potential. Now, when we're applying the electrodes, again, it depends on how many channels you actually want to monitor. But we can do the cross cerebral mode. That just requires 3 electrodes, 2 on the head and 1 ground or reference electrode. Or we can do bilateral monitoring. And with bilateral monitoring, that means that we actually have 4 electrodes on the baby's head and a ground or reference electrode, now we have the 3 channels, because we're looking C3, P3, C4, P4, and we're looking P3, P4 across the whole of the infant's brain. Now, once we've got these electrodes on the baby, we want to understand what it is that we're looking at on this aEEG trace. So I want to talk about the scale on the trace. So when you look at an aEEG screen, we see a semi-logarithmic scale. And that means that it's linear from 0 to 10, and then above 10 up to 100 microvolts, it's logarithmic, it's more compressed. And this is important because it is these values below 10 that we're most interested in, the lower microvoltage values that's depicting to us less brain activity. And what we're actually looking at here is the peak-to-peak values of the EEG. So this aEEG trace is actually reflecting the maximum and the minimum peak values of the raw EEG that is scaling across the bottom of the screen. And then this is plotted, it's time compressed in the aEEG to 3 hours. Basically what we're doing is we're taking 15 seconds of our raw EEG and we're plotting it in one line. We're basically drawing up and down on the trace for 15 seconds in one place, and we're plotting all of the maximums, all of the minimums, and that's what's creating this nice aEEG trace for us. So like I said, I will just run through quickly with you how this is actually modified. So this next screen that you see is giving us, just imagine this is raw EEG, which we know is quite random. It shouldn't be uniform. If it's uniform, it's probably seizure activity. But we've got this random EEG, and we know that with raw EEG, we are looking at positive and negative excursions. It's got positive and negative attributes to it. It's pure electricity attributes to it. And the first thing we do, because we're not interested whether it's positive or negative, we're interested in how big the peaks of microvoltage actually are. So the first thing that we do is we do what's called rectification. We take all of those negative peaks and we flip them upwards. We rectify them into a positive plane. Then the next thing we do to that is we filter it. We apply quite a strong filter in aEEG between 2 and 15 hertz, and this helps to smooth this trace and helps to reduce artifacts. And then what we do with that filtered data is we start to time compress it. We basically time compress it backwards until we get our raw or our basic aEEG trace that we see displayed on the top part of the monitor in the aEEG screen. And once we've got that information, then we can start to look at analysing it. So in order to begin categorising aEEG traces, we must be able to visually define what we call the upper and the lower margins. So I've actually theoretically drawn these on here for you. Red is the upper margin, green is the lower margin. And this, when the aEEG trace is built, it creates this central band. Can I ask whoever's not on mute to go on mute, please? Because there's a bit of background interference here. Thank you so much. When the aEEG trace is built, it creates this central band pattern, which represents where the majority of the brain's activity has been taking place. And you see here that there are some spiked areas above and below that darker band. That also reflects brain activity, but the majority of the brain function is displayed in that dark band. And the top of the dark band, say marked here in red, is, like I said, the upper margin, and the lower band, the marked in green, I say that's what we call the lower margin. But it's not just margins we're looking at. We're not just looking at the upper and lower activity. We're also interested in what is known as either sleep-wake cycling, or more recently is known as cyclicity of the brain. And the presence or absence of sleep-wake cycling, again, may be used to determine a trace category. And even more in babies who've got hypoxic ischemic encephalopathy, this the return of sleep-wake cycling may be predictive of outcome. And sleep-wake cycling is characterized by these smooth sinusoidal variations, generally mostly seen in the lower margin, but we do see the whole trace kind of snaking across the screen. And during this sleep-wake cycle, the broader bandwidth that you see there represents more discontinuous background activity, and that's during the quiet sleep period when the brain is less active. The more narrow the bandwidth, that corresponds to more continuous activity during wakefulness, active sleep, and generally quiet sleep lasts for about 20 minutes. So the entire sleep-wake cycle should last approximately 60 to 90 minutes. Now, in terms of categorizing these traces, how do we do this? Well, there was a very thorough paper published, and I always say to people, if I can recommend you one paper to read, this would be it. And it's a paper published by Professor Lena Hellström-Vestas et al. Professor Hellström-Vestas is from Sweden. She's one of the pioneers of amplitude integrated electroencephalography in newborns. And this paper really looked at the aEEG classification and interpretation in both preterm and term infants. And we do have to remember that when we're interpreting the trace, we have to think about the gestational age of the infant. Again, we'll cover this more next week. But by the end of reading this article, really the reader should be able to understand aEEG, the method, its utility, its limitations, to classify and interpret the typical aEEG background patterns, to identify epileptic seizure activity in the aEEG, and also to be able to describe the features in aEEG that are associated with prognosis. Now, again, within this paper, they've written a really nice section that really helps guide in reporting on the aEEG trace. And I always say to people, you know, if we're applying a technology or a monitor to an infant, we actually have to document the results. We can't just put it on and forget about it. We wouldn't do that with a physiological monitor. We're always writing down the heart rate and the respiratory rate and the oxygen saturations, etc. So, you know, good documentation, it's essential with any form of monitoring that we perform in the NICU. And they basically have stated there's really only three things we need to report on the aEEG trace. That's describing the background pattern, describing the cyclicity, and describing the seizure activity. And as we move through the next part of this presentation, I'm going to give you guys some patterns, and I'm going to ask you these three questions. I'm going to ask you to describe the background pattern, describe the cyclicity, and describe the seizure activity. But before we get to that, I do have another question for you. So I would like to know what you actually expect from aEEG. So I'm going to launch this poll for you. And again, if you would like to vote on that poll, it should come up. There you go. What do you expect from aEEG? Do you think it offers you valuable information with consequences in therapy? Does it offer valuable information with no consequences in therapy? Does it offer a little additional information or no additional information? So just interested to see what the general consensus is from people. I can see a good majority of you have voted. For the sake of time again, because we don't have so much, I'm going to share those results with you all. So you can see as these results will come up in a moment for you, 91% of you believe that this will offer valuable information with consequences in therapy. 6% valuable information, but no consequences in therapy. And as we go down, and I want you to just look at that slide, remember those patterns, because I'm going to share with you a study that was done by a friend and colleague of mine in Germany. And they did a survey amongst every neonatal unit in Germany, and they asked exactly that question, and it's really quite amazing. They got exactly the same pattern that we've just got here in terms of what people thought. And again, here, you know, nearly 90% of people really felt that aEEG offered valuable information with consequences in therapy. So it's really interesting. Wherever in the world we do this poll, we always get this same result. So I was interested to see from you guys. Okay, moving forwards then, let's have a quick look at this classification framework. Like I said, Professor Hellström-Vestas and her colleagues, they put together this very comprehensive classification framework. And basically, when we're talking about background pattern, there are 5 traces, simply 5 patterns that we need to learn what they look like, why they look like that, And then is that normal or abnormal for that infant at that point in time? And basically what we're looking at is the thresholds of the margins. So in micro voltage, what's the value at the lower margin? What is the value at the upper margin? But again, as we mentioned, in addition, we also want to know about the presence or absence of cyclicity. That's a very important factor. So it's time for you to all answer another question. Before we go on and describe each one of those patterns briefly, I want to ask you all, how do you feel about interpreting the neonatal aEEG? Do you find trace interpretation very easy? Is it okay? But I'm sometimes unsure. Does it concern you? Are you very worried about interpreting the traces? Or do you need more education? Okay, so I'm watching these results come in. I am going to give you a couple more seconds, see if anybody else votes. I'm going to close the poll. Very interesting results. Close the poll and share those results with you all. So when that comes up for you guys, 8% of you find it easy, fantastic. 25% of you find it's okay. Combined together, 12% it concerns or worries you, and 55% of you need education. It's why you're here. We're very pleased you came, and this is exactly what we hope to do for you, not just through this session, but with other tools that we'll share with you as we move forwards. So thank you for answering the question, and I'm going to move on, and we'll go into actually interpreting those traces. So as I talk about interpretation here, I'm talking about interpreting for full-term babies, okay? Because next week, for those of you who will join us, hopefully all of you, we'll talk a little bit more about the preterm infant. First of all, just want to recap, with the encephalopathic patient, we know why this is important. It's very important in these encephalopathic kids that we assess the aEEG background activity. So is it normal, moderately abnormal, or severely abnormal? It really helps us to determine the presence and the severity of that injury. It can help us assist in determining how quickly we might want to do an MRI. If we've got a really bad trace in those first 2 days, we might want to do an MRI quicker to make a decision on the forward pathway of care for that infant. Absolutely, it helps us to evaluate the effect of the anti-epileptic drugs that we're giving. Really helps us to define seizures as part of the overall picture, and most importantly as well, it helps us with prediction of the neurodevelopmental outcomes. So as I mentioned, there are 5 patterns. I'm going to briefly describe each of them for you. Take note at this part, because this is the part where we're going to, at the end, give you some patterns we want you to vote on the background pattern, the cyclicity, and the presence of seizures. So the first pattern here is what we call continuous normal voltage. And continuous normal voltage, it appears as this quite narrow band of activity. It ranges anything from kind of 10 up to 40 microvolts, and it will include sleep-wake cycles with this period of about 60 to 90 minutes. And that's when the infant cycles between this active and quiet sleep, and we see the trace appearing as this kind of wavy pattern with these more discontinuous areas in it. Now, in a healthy infant, there will be continuous electrical activity at a fairly high level, and this will generate this upper margin in the range of, let's say, 20 to 50 microvolts, and the lower margin in probably the range of 10 to 20 microvolts. And in general, if the upper margin is above 10 and the lower margin is above 5 and we see cyclicity, we would class this, consider it a continuous normal voltage trace. And in a clinically normal baby, that means their physical examination is also normal. This would be extremely reassuring. Okay. Do you want to mention about the variability? Variability refers to the bandwidth of the trace, and the bandwidth is actually determined by the difference between the upper and the lower margins, and a continuous normal voltage trace in that more awake phase will generally have limited bandwidth variability. And here you see, just before we move on, that first picture is a single channel, that's the cross-cerebral channel, and then we see continuous normal voltage in the bilateral channels, the left and the right side of the brain. The next pattern that we'll move on to is the one that we call discontinuous normal voltage. And that discontinuous normal voltage trace, you can see it looks very different to the continuous normal voltage. And what's really important to note about discontinuous is that whilst the upper margin is still actually above 10 microvolts, so that's representing some high level activity, the lower margin has dropped below 5 microvolts, and that's indicating periods of low level brain activity, which when you look at that raw EEG, you can actually see those periods of, more limited activity versus the periods of more normal activity. So this kind of also translates into an increased bandwidth variability because the activity is no longer organized. And the more discontinuous or disorganized the EEG activity, the wider the trace will become. And you also see there's no longer that wavy pattern that's indicating the absence of sleep-wake cycling. What's important to note about discontinuous activity is that while that lower margin does drop below 5 microvolts, it doesn't go all the way down to 0. Okay, you can see it's not at 0 here, and there are periods of higher brain voltage and periods of voltage, which is, as I say, causing that electronic pen that's drawing that peak-to-peak voltage to create this wide pattern. And this pattern would be considered moderately abnormal for a full-term baby, and it can be a qualifying trace in many global hypothermia protocols. The next pattern that I will move into is the one that we call burst suppression. Now, burst suppression looks very different to either of the first two traces that we've actually seen. So I'm just waiting. There we go. Burst suppression, it's severely abnormal in both the term baby and the preterm baby if we see it continuously. It can, without this grayscale feature that you see on the aEEG here, it can have a similar appearance to discontinuous normal voltage. But when you look at this raw EEG here, you see that that raw EEG is really quite flat, and then it displays these bursts of activity, lasting probably between 1 and 3 seconds. And again, that would then be followed by periods of severe suppression, very low, almost flat voltage background activity. Similar to discontinuous, there's no waviness to that pattern. That's indicating the lack of sleep-wake cycling. And the upper margin actually is above 10 microvolts, but that's due to those very high voltage bursts. Lower margin is below 5. It's almost at 0 in many cases. And there is really there's also increased variability in the bandwidth. Now, the key differentiating factor between this and discontinuous is that there is no variability of the lower margin, or very little. It's almost a straight line, and that represents true suppression in that EEG is flat between the bursts, hence the name burst suppression in the aEEG pattern. So it's this kind of straight line at the bottom that really distinguishes burst suppression from a discontinuous normal voltage trace, especially in a system that may not have a grayscale feature like this, where we actually do see it quite clearly. Now, as the time intervals between the bursts of brain activity increase, the pattern can start to look like a really fine-tooth comb. The longer the interburst interval, the longer the period of very low or almost flat activity, and therefore that's a sicker brain. Interburst intervals within a burst suppression pattern are often classified as burst suppression plus. That means you're showing more than 100 bursts an hour, or burst suppression minus. That means you're showing less than 100 bursts per hour. And clearly the latter indicates a sicker brain. And you can see here a similar pattern on both sides in the two-channel view. The fourth pattern that we describe, or is described by Professor Hellstrom-Vestas and her colleagues, is the pattern that we call continuous low voltage. And as the name describes, it's also severely abnormal in both the full term and the preterm infant. And the raw EEG waveforms, when you look at them, they really are continuously in that low amplitude, less than 5 microvolts. There's no waviness. It's indicating the lack of sleep-wake cycling. The upper margin is really below 10 microvolts now. It's really dropped. The lower margin is below 5 microvolts. There's a small bandwidth. It's indicating some variability in activity, but it's at a very low abnormal voltage. And from experience and from talking to clinicians globally, really, this is the pattern we see least frequently out of all of them. The final pattern that we actually describe is the one that we call the isoelectrical flat trace. And clearly, again, this is severely abnormal in both the full term and the preterm infant. There's no sleep-wake cycling. Upper margin is below 5. Lower margin is almost around 1 microvolt or 0. The continual extremely low voltage or flat brain activity creates this dark, very narrow band near to 0. The patterns has really got greatly reduced variability, both in terms of the bandwidth and the lower margin. And it's representing, as you see in the raw EEG here, it's representing this prolonged flat brain voltage that may occasionally be accompanied by a burst of activity, but often, and the trace you see here with these kind of spikes, that's probably artifact from actually moving and handling the infant. So it's always important to remember about artifacts can artificially give you something on the trace. And you'll see here now, this is just coming in a similar pattern in the two-channel view. We see it mirrored on both sides of the brain. So that's the 5 background patterns. And then, of course, we can see seizures. And seizures may often look unique in the aEEG. They may cause the lower margin of the aEEG to suddenly increase and cause a narrowing of the aEEG bandwidth. And with seizures, the upper margin may or may not increase. And just think about how we build this trace, because this digital pen is moving up and down on top of itself for 15 seconds. It's recording that peak to peak activity. Seizures that are of very short duration, they may be difficult to identify, they may be missed. And also important again to remember that some artifacts can actually artificially raise the lower margin. But since seizures generally, they create this rhythmic discharge of brain activity, it's important for the clinician to validate any suspected seizure in the aEEG by looking at that raw EEG. And this rhythmic spike pattern of the EEG, it really must be present for greater than 10 seconds to be considered a seizure. And you can see hopefully here in just a moment, so this pattern to the left is of seizures bilaterally, and this pattern to the right is a unilateral. It's the cross-cerebral view of the infant's brain. Seizures also, we know, can clearly manifest as status epilepticus. And with status epilepticus, we get this kind of sawtooth pattern. This sawtooth pattern really is reflective of the condition of status epilepticus. So bearing in mind we've just described all these patterns, I now want to ask you really a similar question. So now I want to know, now after just going through all of that, now how do you feel about interpreting the neonatal aEEG? Do you think you're going to find it easy? Do you think it's going to be okay? Have we educated you? Do you still need education? And that's absolutely fine if you do. Let's see what people think now. It's very interesting to see the votes come in from my end, actually. I'm going to close the poll for the sake of time, and I'm going to share those results with everybody. So now, excuse me, everybody. Now, 24% of you now, that's increased, will find the trace interpretation very easy. 43% of you now think it will be okay. 22% of you say it still concerns you, and that's absolutely fine. 12% of you versus 55% think that you need more education. So hopefully we did an okay job in educating some of you, but now nobody is very worried, and that's great news. So great job by everybody for taking part in that poll. Thank you. I just want to briefly mention a little bit more about seizures. So we know that seizures, it's the most distinctive signal of neurological disease in the newborn period. But what's important with seizures is actually also looking at the background pattern at the beginning of seizure activity, because it's that background pattern is actually the main predictor of the neurodevelopmental outcome. So if you've got an okay background pattern with seizures on it, you potentially have a better prognosis than the bottom picture you see here, which is clearly a very bad, probably burst suppression, if not flat background pattern with lots of seizure activity. We know with seizures, aEEG, again, it can help us to detect and to monitor seizures in the high-risk patients. It can help us to verify clinically suspected seizure activity. It can really obviously help to detect subclinical seizures, and it can help us to monitor the effect of the anti-epileptic medication we've given. Actually, that top picture that we see here, you can see that this baby was having, well, almost status epilepticus situation, especially on the left side of his brain here. And about halfway through, he was given medication. And we can clearly see the effect that the medication has had on the seizure activity in that newborn's brain. So let's go on and have a think about, out of these babies in the NICU, who's at risk of developing seizures? Well, really all infants requiring intensive care, they're high risk, especially, as we've mentioned, the encephalopathic infants, infants with congenital malformations, the very sick babies, sepsis, meningitis, babies on ECMO, babies having surgery, the extremely preterm infants, especially those with intraventricular hemorrhages and periventricular leukomalacia, and infants with metabolic problems, including hypoglycemia. And this next slide actually is depicting a study that was done by some colleagues in Austria, headed up by Monika and Katrin Klebermas, and they actually looked at aEEG in metabolic disease. They've done quite a lot of work into this field, and they were looking obviously at the background pattern, but specifically at the number of seizures, and it really depended on the category of metabolic disease as to the number of seizures that were detected in these infants. So I think this one slide alone, this study alone, really it puts into perspective that these infants absolutely, they deserve to have their brains monitored, so we can potentially see this activity in an objective manner. Now, just want to go on and talk about the kind of the challenges we have with neonatal seizure management. So the first thing we know, clinical recognition, it's not reliable. Often these babies are very subtle in presentation with the way they present, even less apparent when they're sedated or paralysed. And there's been lots of studies looking at this. I mean, the study back as far back as 1987 actually showed that 2/3 of seizures people thought were clinical seizures have no EEG correlate. They weren't seizures. The study, and I'm going to allude to this one a little bit more on the next slide, this is a study headed out of Ireland. Less than 10% of seizures are correctly identified clinically. And as we all know, the majority of neonatal seizures actually are subclinical. And also what we really know is the best anti-epileptic treatment strategy, we're still all working on it. There's a lack of randomized controlled trials, especially looking at the long-term follow-up. We're all still playing with which medications we think are most efficient. Which infants are we going to provide the prophylactic treatment to? And we also know with anticonvulsant medication that we can get unpredictable results. Even after giving phenobarbital, at least 50% of seizures can continue but just become subclinical. It gives us this false sense of confidence if we're only looking at these babies clinically and not monitoring them. So often without the monitor, the effectiveness of anti-epileptic treatment strategies is very difficult to evaluate. So this is the premise of a bedside brain monitor, that it gives clinicians this reliable way to know when the seizures have actually been controlled. So this was the study that will come up now that was looking at the clinical observation of seizure activity. A study headed out of Ireland. They looked at 51 newborn infants with HIE. And in a nutshell, this is what they found. 9% of electrographic seizures showed clinical signs which were detected by people at the bedside as seizures. So actually only 9% of the electrographic seizures were correctly identified at the bedside. What's more worrying is that 73% of clinically recorded seizures, that means me as the nurse at the bedside, I'm looking at the baby and I'm going, oh yeah, he's definitely having seizure activity. 73% of those infants had no electrographic correlate signs of seizure activity. So that's 73% of infants who potentially may have got loaded with phenobarbital unnecessarily. And we all know we don't want to give these medications unless we really do have to. So identifying seizures is a really, really important part, and aEEG has a very strong part to play in assisting in doing that at the bedside. And this is actually why within the Olympic Brainz monitor, we actually have seizure detection software. And this is a software called Recognize. It's a module within, it's a standard module within the monitor, incorporates this patented proprietary seizure detection algorithm that detects events that may correspond with seizure activity in a patient. I mean, it's basically alerting the bedside clinician to areas in that aEEG and EEG that may require review, may need more attention by clinical staff. And so we want to go in and look further. And it's simply denoted by these orange marks that you see on the aEEG. And then we get an orange strip along the raw EEG that's telling us this is the seizure activity section. Moving on, just to summarize in terms of the patterns, we said there were 5 background patterns and seizures that we see. And some of you said, We're a little bit worried about interpreting the patterns. I need more education. I'm still a little unsure, and that's also great news because as well within the Olympic Brainz Monitor, we have a software that is called the neonatal background pattern classification algorithm. So now, along with the detection of subclinical seizure identification, now the Olympic Brainz Monitor can also provide you feedback on changes to the background pattern, and it's there to assist you during cooling or other monitoring scenarios. So now it's the turn of you guys to have a go at interpreting these traces. So I'm going to give you 3 pictures of an aEEG trace, and I'm going to ask you the same 3 questions about each picture. We're going to start with what is the background pattern, then do you see cyclicity, and then do you see seizures? So let me just enlarge this one up for you. First of all, take a good look at it. Look at the values on the side in terms of where the microvoltage is of the upper and the lower margin. And I'll launch that first question about that poll. So what is the background pattern of that trace? Is it continuous normal voltage, discontinuous, burst suppression, low voltage, or an isoelectric flat trace? Okay, so what do you think the background pattern was there? Okay, I'm going to, for the sake of time, close the poll. You're all pretty good at this. I've got to say, I'm going to share the results. So I can tell you that 73% of you were correct. It is continuous normal voltage because the upper margin is above 10, the lower margin is above 5, and there are other features in that trace that would make it continuous normal voltage. So let's ask the second question. Look at the picture again. Is there cyclicity? Do you see that sleep-wake cycling? Do you see that waviness, sinusoidal piece that you would say was cyclicity? So yes, no, or you're not sure. Let's see what people said. So we'll close that. And again, excellent. 88% of you were absolutely correct. We do see cyclicity in that trace. We're seeing that narrowing and widening of the bandwidth. We're seeing that sinusoidal look to the trace. So yes, we do see cyclicity. And so let's ask you the third question, which is going to be, do you see seizures? So do you see seizures in that trace? So you either don't see any, or you saw a single seizure, you saw multiple seizures, you thought it was status epilepticus, you're not sure, or maybe you're having a seizure. Who knows? Right, okay, again, a lot of you very good on all of this. I'm going to close the poll, share the results. So 69% of you said no, which is correct. Just eyeballing that aEEG trace, I would say no. However, remember also what I said. I also said that we must validate anything we see on the aEEG with the raw EEG. And as a bit of a trick, I haven't given you the raw EEG there. But just eyeballing it, I would have said no, no seizures. Okay, let's move on to the next trace then. So please take a look at this next pattern. This is now 2 channels. Now I want you to look at both sides of the brain. I'm going to again ask you the same 3 questions. What's the background pattern? What's the cyclicity? And do you see seizures? So again, take a good look at it. Look at the shape of that trace, the symmetry of it. Look at the values of the upper and the lower margin, and think about what is that background pattern. Think, do you see cyclicity? And think, do you see seizures there? So I'll ask the question about the background pattern first of all. So what do you think the background pattern is there? Do you think it's continuous normal voltage? Do you think it's discontinuous? Do you think it's burst suppression? Do you think it's continuous low voltage? Or do you think it's an isoelectric flat trace? So again, lots of people voting. Everybody's getting very good at this. 70% of you were correct. It is a burst suppression trace, and what distinguishes this from the discontinuous is that we've got no variability of that lower margin. It's very, very flat, and with the grey scaling, it's also very, very dark. That's telling us that's where most of that microvoltage activity was taking place, right near the bottom end of the scale. You look at the raw EEG, that's right, I meant to show you the pattern again. If you look at the raw EEG, you clearly see it's very flat, and then this high voltage burst that's appearing at the end of the trace. So yeah, that is a burst suppression pattern. So now thinking about what we know about burst suppression patterns, is there cyclicity? Do you see the waviness, the sleep-wake cycling? Do you see the narrowing and widening of the bandwidth? And again, think about what we know about a burst suppression pattern. Do you see cyclicity? So I'll close that poll, and 90% of you correct. There is absolutely no cyclicity in that pattern. It's just completely flat. There's no changes. There's no waviness across the screen. So no, we're not seeing excuse me, we're not seeing the cyclicity in that pattern. And then the final question on that one is, do you see seizures? So do you see seizures in that pattern? No. Or do you think you might see a single seizure? Do you see multiple seizures? Do you think it's status epilepticus? And again, I'll bear in mind and tell you that where that red line is on the aEEG trace, that is the point of EEG that we see at the bottom. Okay, so take a look at the raw EEG as well. What do you think that we're seeing here? So I'll close the poll and share those results. 50% of you said no. I would agree with 50% of you, especially at this point in time that we have the timeline cursor. This is just pure burst suppression, so very flat activity and then a high voltage burst that would then go flat again. Again, remember, if you think you see something that's seizures, take your timeline cursor to that point in time, and then you can validate with the raw EEG whether it really is seizure activity. Okay, so we're going to go on and look at the final pattern. Again, the same three questions are going to come up. So is this, what's the background pattern? And do you see cyclicity, and do you see seizures on this pattern? So think about the background pattern first of all by looking at that trace, and I will open that poll for you. Okay, so do you think it's continuous normal voltage, discontinuous, burst suppression, low voltage, or a flat trace? And we're a little slower in voting this time. That's not unusual on this trace. People are often torn, as I can see you guys are, between two answers here. So I will, for the sake of time, again, close that poll. I'll share the results. So 60% of you said it was discontinuous. 21% of you said it was continuous normal voltage. Now, it's a really hard one to define here, because that lower margin in the parts where something else is not happening in that trace, the lower margin is sitting really at that 5 microvoltage line. The upper margin is above 10, but look at the bandwidth. The bandwidth is quite wide. So a lot of people would classify that background pattern probably as a discontinuous normal voltage. And I have this debate with a lot of my neonatology colleagues on patterns like this all of the time. That one is a really difficult one to define clearly, the background pattern, because there is something else going on in that trace that is making it more difficult for us to determine. So I'm going to ask you the second question, which is there cyclicity? Do you see cyclicity in that trace? Do you see true sinusoidal variation in that trace or not? Or are you not sure? And it's fine to be not sure if you want to vote not sure. So again, I'll close the results, share them with everybody. very split. 43% of you think yes, 51% of you think no, and 6% of you are not sure. I would probably say no, because when we look at the areas of the trace where there is not something else happening, there's not really true sinusoidal variation. We haven't got narrowing and widening particularly in there, but something else is happening, which is hopefully a clue to the last question, which is, do you see seizures? So tell me, do you see seizures? Do you see a single seizure? Do you see multiple seizures? Or do you see status epilepticus, a pure sawtooth pattern all the way across the screen? Or are you not sure? Or there may be somebody in the audience having a seizure. I'm only joking, guys, I hope not. Right, so I'm going to close that poll and I'm going to share those results. So 77% of you were correct. Yeah, there is multiple seizures in this trace. It's not status epilepticus, it's not a pure sawtooth pattern all the way across the trace, but definitely we see multiple seizures. I'm going to move quickly now because I know we want to go to the panel discussion, just to mention about preterm babies, and I'm not going to focus on this because this is the subject of next week's session, but just remember that when we're interpreting the preterm trace, we expect it to look different because their brain activity is much more disorganized. But all of these things we will actually cover in next week's session, and we'll talk a lot about the prognostic value of aEEG in preterm infants. I just want to finish off with thinking about how many channels. We've mentioned that with the Olympic Brainz monitor, we can monitor 1, 2, or 3 channels. Now, this was a really nice study, and a friend of mine from London was involved in this study, actually, Divyan Shah, where they looked in comparison, they simultaneously measured 1 and 2 channels of aEEG, as you see in the pictures here. And then they did the MRI in these infants. There are 28 patients simultaneously monitoring 1 or 2 channels of aEEG. They did an MRI for identifying cerebral damage and for looking at neurological outcomes after 2 years. And in 4 cases, I had 4 cases where the single channel aEEG was normal, but the bilateral aEEG was abnormal, and that was because it was either a unilateral or a very focal injury. So I think that really talks about the importance of having that additional information. It really gives us so much more information having those additional channels. So on that note, I'm going to close. I just want to point all of you to our education platform, which is the Neonatal Care Academy. On the Neonatal Care Academy, excuse me, on the Neonatal Care Academy, you will find many courses, e-seminars, recorded events, all led by key opinion leaders that will really help guide you through the use of aEEG clinically, you know, learning how to interpret, learning how to use it in other populations outside of the infant with hypoxic ischemic encephalopathy. We have a wealth of resources, courses that you can order as hard copies of DVDs that you can keep in your library. We have a wealth of case studies, excuse me, that are downloadable. You're very welcome to download them. And on that note, I'm going to say thank you, and I'm going to hand back to Dr. Dinakar and Dr. Prashant. Thank you.
Yeah, Prashant, there are questions are there. I think so. We will take to our all the questions. We will take by our panelists, because there are questions. Panelists are there. Dr. Neha, Monika, Prathap, Leslie, and Jafar. Everybody is there. I think so. All the questions they can answer. Number 1. Number 2. Please, Judy, excellent, elaborated talk, beautiful. I think so all the preterms we are going to cover and other things in the next session, that is on the 29th. Then on the not only preterm, I think so exclusively preterm we are going to cover on 29th. Then about all the other things like perinatal stroke, metabolic disorder, cardiac problem, then not surgical problem, muscle relaxant, sedation, ventilator, what not, all the other things we are going to cover on 5th of August. 5th of August we are going to cover. That's what our plan is. Thank you very much once again, Judy. If you are there in the panel, we are very happy. I think so Dr. Kiran is, so there is some problem with his laptop or something. He's trying to join us shortly. In the meantime, Dr. Kiran, if he is joins, let him take over the panel, this thing. In case if it is not, either any our panelists can take it. Prashant, please go ahead with your this thing.
Yes, sir.
Welcome all this thing, Dr. Prashant.
Yes, sir. Yes, sir. Yes, sir. Thank you, Judy. Wonderful presentation. We will move on to the panel discussion now. And I request
Can you
Judy to
introduce
be
all
around.
the panelists, Prashant?
Yes, sir. Yes, sir. Yes, sir. Yes, sir. So we have a wonderful panelist from across the globe now. So Dr. Monika, she's from Dubai. Welcome, Dr. Monika, for the panel discussion. And we have Dr. Prathap. Yeah. Sir?
No. Okay. Prathap, yes. Monika, yes, please.
And yeah, Dr. Neha from UK. Welcome, Dr. Neha. And Dr. Leslie from India. Welcome, Dr. Leslie. And Dr. Kiran from Qatar. And Dr. Jafar Khan from India. Welcome, panelists, for today's discussion on amplitude EEG.
Kiran is joined.
And since I've been getting a lot of messages because most of the people who have joined today's session, they're all beginners, and they've requested the panelists to summarize the entire thing, what has been covered by Judy with the live demonstration. So I request Dr. Dinakar, sir, is it possible to show the live demonstration, sir?
Yeah,
with the machine.
Yes. As and when our panelists are going to talk, in case if it is necessary, we are going to show how to prepare the skin, how to put the leads, how to switch on the machine, how to go ahead, and about that what is that artificial intelligence, everything we are going to show. Everything will be live virtual demo we are going to give after each session. Even if Dr. Neha is having some questions, if she wants to talk about what is the meaning of artifact or something like that, if she wants to show everything with a live demo, we can show it. If the panelists are requested.
Yeah, I've been getting messages from attendees that they want, because since it's a beginning and their first time they are learning this, they requested that today's class, they wanted it to be little simple from the panelists as well. Like what are the things which has been covered, they want it to be summarized like a gist. So I request all the panelists to when you're presenting it, when you're telling it, please think that this is the first time they're listening. So try to make it simple and make it very easy for them to learn. So we'll move on to the panel discussion now quickly. So this is for Dr. Jafar Khan. Sir, can you show us how to arrange CFM, how to fix the lead operation? Dr. Jafar Khan, sir, are you there?
No.
Over to you, sir.
Show the video. Turn this side, man.
Dr. Jafar?
Yeah. Can we have the doll?
Yeah, we can.
Demonstration?
Sheila.
Yeah.
Okay, video. You tell them you are showing video. Demo, you should call them.
So we have to arrange the machine. We have to arrange the leads. We have 3 type of leads available with this type of CFM.
Can we see here?
We have one lead which is reusable, that is gold cup. The second type we have that hydrogel, and third type of leads we have that hypodermic needles. So when we need for a very short time monitoring, we can use the gold cup with conductive gel. But if we need for long time, we can use that hydrogel, or sometime we can use for hypodermic needle. First, after arranging the machine, we need to prepare the skin preparation first. We need to clear with some aseptic solution the skin and whatever residues on scalp. Then we can use that skin preparation gel what we have provided. We can use that also. If there are so many hairs or thick hairs, then we can use some little comb. So just apart the that hairs, and then we can the area where we want to apply the that our hydrogel or needles, that should be hair should be little bit aparted with hair, with either earbuds or some sticks. So these three things we are showing in the screen. One skin preparation gel, that gold cup, then hydrogel and needles also. So after yes, that earbuds we can use for separation of the these hairs. Okay, after preparation, we have to measure the distance where we need to apply our sensors. So for that we have scale. There are two type of scale. We have one for preterm, which is pretty smaller, and one is bigger one, that is for term maybe. So the in this scale there are three distinct marking is there. One each side there is a B C D, and in between there is a arrow. So there are two sides marking is there. One is for sagittal suture and one is for ear tragus. So we have to put this scale that on tragus, and the second side on the uh, sagittal suture. So whatever A or B or C which is comes to the tragus, that same marking should come on the sagittal sutures. Okay, after that arranging the side, then we have to mark at the side where the arrow is coming. So anteriorly we are marking, and then posteriorly we are marking. So in anteriorly we are placing the C3 and and posteriorly we are placing the P3 or P4. First we are making on the left side, then same procedure we have to apply in the right side. Okay, so we are marking with the help of marker, and we have to take care that same marking should be at the tragus and the same should be at the sagittal suture. So we have to move little in or outside when we are marking. Okay, after marking, then we have to place the hydrogel. First we have to place that one neutral one hydro gel at the mid of the frontal side. Okay, after, and then it is C3. Then we are applying same. We have to follow this lead to the module. There is a map. Okay, just show the map on the module. There is a module. Okay, so after application of leads, this is P3 on the posterior aspect of the left side. Okay, these are the two left side applied. This one, which is right posterior, that is we can say P4, and the right anterior, which is C4. Now the middle one hydrogel we can apply. Okay, which is just at the mid of the frontal region. Okay, then we have to follow these leads separately one by one. And okay, this is how this it looks like. Okay, and this you can see that there are 5 leads, and you can see the module, and we can attach the leads in the module according to the map. So you can see the map. Okay, and we have to attach according to the C3 and C4, P3, P4 and middle one. Okay, after attaching all these, we can switch on the machine and we can start the recording. Okay.
Yeah.
Yeah. So
Yeah, thank you, sir. Thank you, sir. Yes, sir.
So this is how we attach
We'll,
the
move-
leads.
Yeah, Dr. Prashant.
Yes, sir. Yes, sir.
Yeah. So
Yeah.
number one, thank you, Dr. Jafar. As you told, we are lively doing here. You told
Yeah,
us to
thanks.
connect C3 and P3 and
Okay.
C4,
And
P4,
P4.
P4. So P4
Sir,
is towards
can
the right.
you place the
Or,
page in the center,
yeah.
sir? Yeah,
Yeah.
yeah.
Center.
Little towards your side, sir. Yeah, yeah, yeah. Correct, sir.
Yeah, correct.
Okay.
I
And
request
this
the
is the
audience
reference.
to
This is the reference or
Reference,
a
yeah.
ground gel.
Ground,
Okay. And we
ground
are
lead. Great.
same thing. Accordingly, we are fixing it.
Yeah, sure.
Okay, sir, now everything is connected. Everything is connected. Now baby is like this. Just I'm showing you. Baby is sleeping.
Yeah.
Now we have connected to the machine. Please come near, sir. Come here. See, we have connected this one to the machine. And one more thing, please stay. Please stay. Keep it. Now you go. You go. I think so.
Yeah.
The next speaker is going to tell about what is the leads. So this is the come near, come near, come near, come near. This is the leads.
Gold Cup.
They're going to tell about the leads and this thing. The other speaker is going to talk about the leads. We will tell you. So Dr. Jafar, thank you very much for your question. You have made it very clear. Your question was how to prepare. Number one is this is the preparation. This is one is neoprep. Number one is
Yeah,
this is
neoprep.
neoprep. This is for the preparing the skin. You told, sir. It is excellent, sir. It is excellent. This one, this is a conductor.
Which use
Yes, sir.
for a Gold Cup. Which we use
Yes,
for Gold
sir.
Cup only. Yeah.
Yeah.
This is not required when we are
One
using hydrogel. Yeah.
Yes, sir.
This we should.
Yes,
Yeah.
sir.
This will.
So this is the gold cup.
Okay. We have to take that full of from
Come
the.
on, come on, come on.
Okay. Like what we are taking, like ice cream, now. So
Really?
that is full sip. We have to take
Okay.
because it should have some base also. And with this we have to press at the scalp. Yeah, nicely.
Take. Come on, Neha.
Yeah.
Come
Just
here,
like we
Sheila.
have to press.
Place it, leave it.
Yeah, and we can cover with some micropore or some like cotton which is dipped with. Okay. Yeah. Same, all 4 or 5 we have to apply like this. Okay.
Yes.
This is a
See,
hydrogel.
this is the one.
This is hypodermic. This is a hypodermic needle. We can
Yeah.
use when we use for longer time. Okay, this is the hydrogel needle. Okay. One thing we can keep in mind that when we are placing the needle, it should be quarterly. The direction should be quarterly. Yeah. This should be traced upward. Yeah, this is like.
See, the fixing is an art. Fixing is an art. See the way what she is doing.
Yeah.
It has to overlap.
Yes.
Yeah. Okay, fine.
So it is like this. Okay.
Yeah.
We are fixing it. It is almost fixed it.
Yeah.
Okay. So all the 3 leads you told. Thank you, Dr. Jafar. Thank you very much for taking your questions and explaining. Thank you.
Thank you, sir.
Yeah.
Yeah.
Over to Prashant.
Thank you, Jafar, sir. Yeah, we'll move on to the next panelist. Leslie, sir, can you tell us initiation and final check of the machine about switching off machine, 5 leads, impedance, enter name, and start? Over to you, sir.
Hello, Prashant and Dinakar. Thank you very much, Judy. It is a wonderful presentation by you. And before I go, I'll just quickly summarize. Over the years, last few years, we are using this amplitude integrated EEG for a hypoxic ischemic encephalopathy baby with a hypothermia management. But now, last few years, we have moved into a neonatal encephalopathy. And possibly in future, we have to go into a preterm brain monitoring. So that way, that is, I think we'll look into the next sessions. What we have last 5 years, we have a couple of missions with us. One is, Prashant, can you change?
Yeah, Dr. Prashant.
Yes, sir. Yes, sir.
Please, the monitor. Can you change? Yes. So this is what, once you connected to the switch on, this is what you get in the monitor. And there is a small icon comes. It's called as a NICU, or it is called as it is also called as the whatever the machine you have. What we have is Nicolette, and the other machine we have is the Inspiron Health equipments. These two machines are there, and once you enter it, then you connected the electrodes, and then power on this desktop or the display will come. And once you get into that, you can enter here what is called as a enter new. And once you enter it, then you can put the details of the baby's details. You can put the hospital number. You have already have a hospital number that will again display. That is your re-recording, or the subsequent recording will come for that day as well as the time. If it's a new case and this recording is not done, then it will display as the new case only. So once you switch on, go to the new patient, and then you enter the neonatal details. Next slide. Any change?
Yeah, Prashant.
Yes, sir. Yes, sir. Yes, sir. Yes,
And
sir.
this is, once you enter, this picture you will get on your machine, and is already is there. This is what we get in our machine. They may be a little different in other machines what you get, and Dr. Dinakar is already showing in the background that picture. And this is where you will get that module, and then it will starts running. Next slide.
Yeah, Prashant, one second. After entering the patient's details in the Natus CFM machine, so whether you are choosing 3 leads or 5 leads, 3 leads means single channel.
Yes.
5 leads means 2 channels. It will come. It will show like this.
Yes. But
then we have to press. Once it is pressed, it has come. Start.
Okay.
Yeah, please go ahead. Go ahead, Leslie, now.
What we have in our machine, we have already incorporated that protocol. So generally, we do the 2-channel recording. Okay, and then you get the impedance check is there. Once you are single channel or 2-channel, whatever you entered there, then you get the impedance check. Once you get here impedance check, you can see here multiple the red lights are there. That means that impedance is not good. Only this here P3 on the left side is a good impedance. The rest all are not good. Some of the machine has got EKG or ECG leads also are there. It's better to take out this in your protocol itself, so that you get only this reference. This is what we get ground, and the P3, P4 or C3, C4 in the double channel monitoring. And this is how we start impedance check. Next, once you get the green signals everywhere, it is ready to start, and you can see here this started recording. This is, I have increased the bandwidth here. This is actually over a period of a minute, but in a TFM generally we get a 6 centimeter running over a period of 1 hour, and you can get this graph is compressed. And you can see here, it's not very clear here. This is the raw EEG, which is getting down here. And this is the raw EEG is compressed over as an amplitude integrated EEG. And this machine is now ready to run. But if you see the quality of that recordings, they are not good. The reason is this impedance is not good. Mostly we had a bad impedance there. We have not got the green channels or signals everywhere. That's the reason we got this kind of the signals. So summing up, remember, so switch on, first collect the electrodes, switch on the machines, select either 3-channel or 5-channel electrodes, and then you go into the impedance check and then run the machines. So, and that is after you enter the baby's name and the hospital number.
Thank you, sir.
Yeah,
thank you, sir.
Yeah, Dr. Prashant.
Yes, sir. Dinakar, sir.
Yeah,
yes, sir.
Just 1 minute. I want to show. See here, this is a raw EEG from here to here. That means this is 15 seconds reading from raw EEG from here to here. It is 15 seconds, means 18 inches is there from here to here. That 18 centimeters, it shows 15 seconds. That complete 15 seconds, it will be converted into the amplitude EEG here on the top, 1 line. That's what Judy was telling. I think so next speakers are going to tell. Whichever the 1 line we are seeing, just one stroke, that is nothing but from here to here 15 seconds reading. That is one thing we have to remember. I think so, that's all. Then impedance, see here, what we are seeing is, see, I have pressed here omega watch, that thing. This is showing, see that. It is a demo. It will show round signal. Any one lead in this machine, if it goes, that will tell whether left side or right side, whether C3 or P3, which is gone in this machine, it will tell you. Once it is there, how much it is picked up. Can you come up here?
Signal.
Yeah, see this? Yeah, finger. Yeah. See, can you show here? This also will be in the green color. Green means safe. So whatever you are getting the record, it is perfect. So impedance is 0. Then your readings are very good. That's what Dr. Leslie is wants to tell. Thank you very much, Dr. Prashant. Over to you.
Yeah, thank you, sir. Thank you, sir. The next panelist, Dr. Prathap. Importance of 3-lead or 5-lead. Can you give us a detail? Which channel is better? Is there any microvolt difference and its significance? Can you tell us about interfaces used? Which is better? Over to you, Dr. Prathap. Dr. Prathap? Yeah.
Okay, fine. See, we grew up like how Judy was suggesting, you know, we were part of the trials and all that. Initially, we only had the 3-channel, you know, the 3 electrodes which are placed and was using the single channel. You know, even then it was okay. It's not bad at all. But at the end of the day, which channel is better? You know, if you're using bilateral lobes where you're using the central channels, the C3, C4, and if you're using the parietal lobes as well, the P3 and P4, that gives you much better information. So the 3-channel ones are you're using the central channels only, and then using your either this as your the ground or on the back of the nape of the neck, whichever one it is all right. But at the end of the day, right now I think majority of the you know, the new machines are giving you the you know, the 4-channel plus the what do you call the grounding as the electrodes. So basically, whenever we talk about the differences. The differences is usually the more the merrier. But on the other hand, the reason we all selected amplitude EEG is because the less the merrier, because we could not cope with too many electrodes. So therefore, at the end of the day, if you use only a single channel electrodes and only on the one side of the hemisphere, if something is happening on the other side of the hemisphere, you're going to lose it. So both sides of the hemispheres, you need to have a control of it. That is the reason why right now the 5 electrodes ones are more useful. And when you look at the microvolt differences and its significance, I think, you know, at the end of the day, the baseline is always same, whichever electrode that you are going to use. And the top line depends on the logarithmic changes, right? So I would say, again, more the merrier. If you use the 5-channel electrodes, it's better. When you talk about the interfaces that are used, you have a gel-based electrode, you've got a sticker-based electrodes, and you've got a needle-based electrodes. You know, in my personal experience, especially if you're dealing with an Indian child with lots and lots of hair, you know, sometimes you might have to shave the hair to fix in that kind of an electrode. And you have to do the prep, like the previous speaker spoke about. You know, the preparation is extremely important. You need to use that sort of a contact gel, and the gel that you use also will abrade the skin a little bit. And that's how, when you see the nurses doing that with like a earbud, you know, you're just cleaning it with that kind of preparation. What they're trying to do is have a clear dry spot. And on top of it, either you're placing your electrode, which is a gel-based electrode and which is like a sticker, or you're placing your, you know, the needle-based electrode. In my opinion, in Asian babies, especially with, somebody can mute if they're already they're on. So if there is a lot of hairs, you know, majority of your Caucasian babies come with very less hair. I just want to give you an example. When my son was born in UK, a lot of midwives just came to look at him just because he had lots of hairs, you know. So just like that, you know, you may have to, you know, you shave the hairs, and then you may have to use the prep really well, and then you may have to use the electrode gel. In my opinion, in a lot of cases where the connectivity, I'm sure Dr. Leslie talked about the impedance. If the connectivity and the impedance is an issue, I would always go for an electrode, which is a needle-based electrode. And it has never failed me, never ever failed me actually. At the end of the day, I think when you look at it, multiple, you know, the dual channel, where you're capturing both the hemispheres and using a better interface depending on the number of hairs your child has got, is always helpful. So practicality comes in this point in time. Right, like you put in the slides, the C3, C4. Always you have to remember the left side of all your electrodes are odd numbers. Left side of all your electrodes are odd numbers. The right side of your electrodes are even numbers. When we say C3, C4, it is center of left and also the right. When we say P3, P4, it's the left side of the parietal and the right side of the parietal.
Thank you, Dr. Prathap. Dinakar sir,
And
would you like to show?
Dr. Monika is going to speak about why it is important to just put the electrodes in those places specifically.
Excellent. Prashant, Prathap has spoke very nicely, very neatly, why to place the channels, why it is important. And he already told one thing excellent. He has given the things, 3 leads. They have started with 3 leads. As it is improved, they have understood why 5 leads is better. Number 1, that's what he told. It's very good. Everybody understood 5 leads are better. I think number 1. Number 2, how to apply everything they have told. Why 5 leads are better? Dr. Prathap Chandra has explained very clearly why 5 leads are better. Because 5 leads, it will also show left and right. Number 1, left hemisphere, right hemisphere. Whatever the pathology is in the right hemisphere, right amplitude EEG and raw EEG also will pick up on the right side. Left pathology, it will also pick up on the left side. So it is easy to diagnose where is the problem. And one more thing is, very clearly he mentioned cross cerebral action also is more important in P3 and P4. Very nice. He told very good. The next speaker question, Dr. Monika, is going to elaborately tell about why that is the places. Okay, over to Prashant.
Yes, sir. Over to Dr. Monika. Why do you, I mean, elaborate on the things? Yeah.
Thank you for inviting, and this is a very relevant and important question because if we don't know where to place and how to place and why to place and the leads properly, then we would miss the main information. So, and I always teach, like, you know, whenever something is told to you, you must ask the question why. And when you ask the question why, you get the answer, then you will be doing things in a proper way. So next slide, Prashant. So the main thing when we talk about it's not just okay, put C3 P3 C4 P4. It has come with some science behind it, and the science says that it all depends on multiple factors, and I'll talk one by one about the maturation of the brain, the topography, where like below what it is, the distribution, the symmetry, the impedance, the artifact by the muscles. Very important. So next slide. About the maturation, when we talk about, we all know that the brain matures from the posterior to the anteriorly, from posteriorly to the anteriorly, and now like what we were talking, like we were thinking that CFM machine is only for asphyxia and hypothermia and cooling, but all of us have started using it in our preemies as well. So people are using from 23, 24 weeks and beyond, and we can pick up many things in that. So when we say that the brain is maturing from posterior to anterior, so we can well imagine that anterior brain is not mature in these 24, 25 week preemies. And even in the term, if you see, the maximum maturation would occur in the center. So to pick up the things, it's better that we place our probes in that part where the maturation is maximum. And especially the frontal part, you say, is it electrophysiologically absolutely not mature, and hence it will not pick up any kind of activity from down to up, and we will be missing out on seizures if we do that. The second part is the topography. Next slide, please. The topography, because we see that we are seeing our aEEG for three things. One, if we look at the premature babies, we are looking at the IVH and the problems what the IVH is causing to the baby's brain. And we all know that the IVH is occurring mainly in the caudothalamic junction. So this P3, C3 position is right on top of that caudothalamic junction when you can actually pick up those abnormalities. Then we are using this for our asphyxiated term babies, where we know that the watershed areas, the watershed area is also below that area. So we can pick up the problem of asphyxia in that watershed area. And also the diffuse abnormality, ischemia can be picked up there. And the third thing which we are usually using it for is the perinatal strokes. So we have perinatal stroke, and we all know that the thromboembolism will occur in the MCA territory, and that MCA territory is also there in that, below that area. So this area is very important, P3, C3 and P4, C4 area. Then this is very important, distribution of neonatal seizures. So actually, if we look at that, from the brainstem, medulla, cerebellum, if the seizures are occurring, then for them to come to the top, it's very difficult, and we might not pick up these seizures even in the C3, P3, C4, P4 area. Forget about the other area. So that's why this area is very important to pick up from the deeper structures more efficiently. Next slide, please. And the next is the symmetry and asymmetry. This is already well taken by Jafar when he talked about how should you place your electrodes, which is very important. So he said that you have to put the marker, and you have the premature and the mature baby's brain, and then you have to mark from the tragus to the superior sagittal, and the marking should be done properly so that both the electrodes have a distance which is very important. If the distance is missed on, then the problem will occur, and if you don't put it in a right place, then also the problem will occur. Now, when you see the asymmetry, as you see here, like in the upper part, there is no asymmetry. There is a little bit here. And in the lower part, you can say the upper, how do we usually say the upper is left and the lower is right? That's how that's the basics of even CEEG and aEEG. So this upper one is the left and the lower one is the right. And you can see this is a very thin and looking quite abnormal, but not fitting into anything. And here also it became little small. So this asymmetry can occur because of other things, like, you know, if scalp edema is there, or sometimes we are putting IV lines there, or scalp hematoma is there, or some injury. So we should know, and we should rectify and then interpret the EEG properly. So this is one thing which is very important. And next slide. And the other thing is the distance. You see, this distance is very important. So that's why, supposing, you know, Jafar was explaining that when we are putting these electrodes, and then you are putting some gel there in beneath, so the impedance is reduced as much as possible. But sometimes still it may, you know, slip. And you can see when it slips, it is going near each other. And how it is shown here, it's going, the width is getting narrowed. Now, this width gets narrowed when they are close, because these activities gets thick, the voltage gets depressed if they are coming, and then they will not be nicely seen. And that's the reason we have to make sure that the distance is well maintained and we correct the position. Also, there are other things which may cause problems, that is the impedance, the ECG, if it is going on, those things also you need to be keeping in mind. And this is very important. You know, we have the muscles here of mastication, and as you can see, if the baby is swallowing, sucking, or even yawning, crying, these muscles will make movements and they will produce artifact if the leads are placed much nearer. So the leads which we have chosen, C3, P4, is much away from these areas, mastication muscles, so they don't get produce that much of artifact because of these movements. And also the movements of the babies handling by the nurses, that doesn't get much affected because of this C3, P3, C4, P4 position. So I hope you it explains and you will remember it, why we have chosen this position. It's with lot of science. Thank you.
Thank you, Dr. Monika. Thank you. Sir, would you like to show it in the baby, sir? Dinakar, sir? Again.
Yeah, Dr. Prashant, whatever she told, it was really excellent, excellent position artifact and all those things. Only one thing I want to tell here is just, I don't know whether you people can see or not. Number one, this is the front, this is the face. Please remember, the baby is like this now. This is the right side. Right side is P4, C3. You tell Ravi to call me later. Okay, P4, C4. And the distance here, what you are seeing, please, why we should always put it here. Now, please see this. This is the significance what Monika was explaining almost. And she explained so beautifully, 6 points to remember. Really excellent, very good, Monika, excellent. All those things, okay, and what she showed here is also excellent, how to place it. Why to place this is very important, dear friends. Why C3, sorry, why C4 and P4? and she told why maximum electrical impulses what it comes. The P4 is the one and P3 is the one it picks up. C3 one alone, C3 is not good. P is very important. That is the reason in 3 leads they used to fix near P3 and P4. But C3 means with the C4 that will also frontal and parietal, and everywhere it, both the things will pick up. That's what, how many leads, why it is, she told. Very good. Thank you, Dr. Monika. And after all those things, we will take Dr. Jody, because there are a lot of questions are there for Jody and our panels also. Please stay on. Next, over to Prashant.
Yes, sir. Yes, sir. This is for next question is for
One more
our
thing I wanted to add, Prashant,
next panelist.
that these markings are different for preterm and term. So you should know that which one you choose. This band what Dinakaran was showing, it's different for preterm and term. So you should know which baby you are choosing and which one to, yeah.
Thank you, Dr. Monika. Dr. Neha, what do you mean by artifacts in amplitude EEG?
Yeah, so thank you so much, Dr. Prashant and Dr. Dinakar, for this opportunity. And thank you so much, Judy, and all my previous speakers for the wonderful talk. And I think Judy has covered almost everything. So I'll try to just add up and just to summarize that what is there. So obviously, artifact means something which is like, in a very simple definition, if I say any electrical activity which is other than the normal brain electrical activities an artifact. Now, this is very, very important to understand, because what happens is that if we don't know how to interpret this artifact, we might inadvertently consider the EEG tracing as an abnormal, and then eventually we end up investing a lot of things, or the management plan and everything will be changed. So it's very, very important for any treating clinician to understand how to differentiate the real brain activity on an amplitude integrated electroencephalogram versus any artifact which is there. So that's why it's important. And the live EEG signal is basically used as a point of reference, where it can confirm the suspected brain activity versus any sort of artifact in a real sense. So that's why it's important, and that's why basically this amplitude EEG has made our life easy. Now, there was a very interesting article which was published in American Academy of Pediatrics in December 2006, where actually they considered 20 newborns who had neonatal encephalopathy. And they did like aEEG almost for 200 hours, and they noted that almost 12% there was an artifact. So it's a big percentage of a number which was actually quoted by this case report article. And that's why it's very, very important for us to know how to differentiate these articles from any real brain activity on aEEG. Now, the causes of the artifact could be many. It could be a muscle artifact, for instance, as Dr. Monika rightly said, if the baby is yawning or his baby is sucking. So these can produce an artifact. It could be a movement artifact, which could be just because baby is crying or making movement, or is jittery, or there's rigidity which is going on. So it could be picked up falsely on aEEG. It could be a ventilatory associated artifact, specifically when the babies are on high frequency oscillation like HFOV, then obviously because of the wobbles, these vibrations can be transmitted to the scalp electrode, which can again be reflected falsely on the monitor as if it's something like a very abnormal traces. So it could be an artifact. And it can be, there could be a variety of reasons, like as Dr. Monika also said about edema or hematoma, or some like, you know, when we put the scalp IV cannulas, and if it is tissued, and if there's any localized edema, then also it can give an artifact. And there could be even because of the drugs, as Judy mentioned about any anesthetic agent or the paralyzing agent, when they are used, then obviously it suppresses the brain activity and becomes really difficult for us to interpret those things. So these artifacts could be produced by a number of reasons. And here comes the role of the clinician, how to differentiate that, because it's very important. And there's a well said saying, the eyes only know what the mind is prepared to comprehend. So we only see what we like, you know, our mind only interprets what eyes see. So basically, sometimes we are fixated that probably this is looking abnormal. And then if you're fixated on that, our line of management is completely changed. So that's why it's very important to address that these artifacts has to be differentiated from the real brain activity. Now, in this aEEG waveform, which you can see in front of you, you can see that the aEEG on the upper side, as Dr. Monika said, is the left one, and the one on the bottom is the right one. And if you clearly see the tracing, you can see that there is, in the initial phase, you can see there's a bit of arching of the lower margin, but the upper margin is still same. So that is looking something weird. It's looking something abnormal. So first of all, it's very important to first see how the tracing is looking. Secondly, paying attention to that area where you can see that is an abnormal waveform. Now, how to differentiate whether this is basically an artifact or is there any seizure happening at that point of time? So the best or the simplest way to look at it is that if you see any lower margin being elevated, but the upper margin still being same, that is an artifact. If it is a seizure, then both the lower margin as well as the upper margin will be elevated. So it's very, very important to understand that any time when there is a muscle artifact because of baby being crying, or if there's a baby is sucking anything or is shivering, then these artifacts can be clearly witnessed. The most important thing is the lower margin is elevated, but the upper margin is still same. And as Dr. Monika rightly explained about the muscle of mastication, that usually these electrodes are placed slightly away from all the muscles of which are involved in the mastication. So usually the benefit of using aEEG is basically that it avoids those artifacts, but sometimes if there's a movement, then erroneously it can be reflected on the screen. Now on this waveform, you can see that there is a waveform which is formed in front of us, and the most important thing to understand for everyone to say that this is a normal waveform or this is an artifact, the three things, the golden rule to interpret any aEEG is that your lower margin has to be above 5 microvolts, your upper margin has to be above 10 microvolt, and there has to be a normal sleep-wake cycle. Any deflection from these three is abnormal. So first of all, this has to be remembered by everyone in order to interpret a normal EEG. And now you can see in front of you in the waveform which is being reflected on the first part, that you can see your lower margin is above 5, but your upper margin is also above 10. So that is looking like a normal. But somewhat at the base, you can see it's basically a little bit dark waveform, and here it is like a grayish waveform. So this could be an artifact, because usually the waveform which is reflected, they are basically predominantly they are grayish in color. Sometimes you can see at the base, you can find some darker waveforms as well, but this is an artifact. So it's important to understand that if you see any waveform, the lower margin above 5, the upper margin above 10, and a normal sleep-wake cycle, then this is a normal one. And in order to differentiate with the artifact, again, if you see a darker base, but on the similar line, like if you can meet these three requirements, then it could be normal. So please interpret any artifact very clearly or any waveform very clearly, because you might be confused because of that. Can we just move to the next slide, please? Dr. Prashant, next slide.
Yeah.
And if, like, you can clearly see that this is a very abnormal waveform where you can see a burst suppression pattern where sometimes it's difficult to even understand that. You can only clearly say that this lower margin is below 5, the upper margin is somewhat like touching 100. So it's looking at very broad traces. Now, whether it's an artifact or whether it's basically a burst suppression pattern, sometimes it can become challenging. But again, you have to consider the clinical situation. And as I said, the high frequency ventilation, because of the wobbles which are generated by the high frequency ventilation, it can be transmitted to the scalp electrode, which can be erroneously reflected on your aEEG in an abnormal way. So please pay attention what mode of ventilation you're giving, or if you're trying to interpret the waveform, then please do exclude these factors in order to be very sure that this is not an abnormal waveform. Yeah, can we just move to the next slide, please? And sometimes even like when we use hydrogel, we use a little drop of water on the scalp electrodes, and this water is only to keep these electrodes in place. And sometimes when the water is being dried up, then the electrodes are easily moved away from the scalp, and that can be seen if you see the last one, the fourth traces here. You can see it is all lower down, like the margins has everything has came down. So that is an abnormal one, and that is not because the child is having abnormal basically any abnormal brain activities. It's just because the water is being dried up, and that's why it's important when you have put the water on the electrode, then you can see a very beautiful traces here. So just be sure whenever you see anything abnormal, you have to ensure that all the electrodes are in well contact, and according to that and based on that, once you have corrected all those things, then you have to see and interpret your waveform. I have not included any waveform here when the babies are being handled or cared. But if the babies are if the nursing staff is there and she's handling the baby, then you can see a very messy, a very abnormal aEEG traces there. So just be careful that when the baby is being handled, then you can come across some of the abnormal waveform, which could be an artifact. So please pay attention, and here is the role of all the clinicians. So please just learn from these things. Over to you, Dr. Prashant. Thank you.
Thank you, Dr. Neha. Dinakar sir.
Yeah, Prashant.
Yes, sir. Yes.
Can you hear me? Yeah.
Yes.
I think so. Beautifully, Dr. Neha has explained in detail, in depth. Very good. So actually, my teacher is Judy More. Everything she has taught me, all those things. Dr. Judy, Judy. I think so. She's there, or I don't know. Okay, she taught me all those things when she came to India. 2 years back and 3 years back and 4 years back. Because till that time I was doing on my own, reading the books, and I used to learn there because individually trained. Later I became little more perfect. See, Neha is become more very good, excellent. She told only 4 things. I request everybody, please follow. She told only 4 things, artifacts. Number 1 is sucking, swallowing, and what is that? Crying, shivering. If anything is there, what happens? Either sucking, swallowing, chewing, mastication, muscles will be in contact and it will move. To avoid that, that is the place. What is happened is we place C3 and P3, C4, P3 away from muscles of mastication according to Monika. Yes, what she told is correct. Even in spite of that, if the artifact comes, she told very clearly how to identify. But one thing, Neha, what you told is very correct. Only thing, lower border will rise in the EEG, amplitude EEG, lower border will rise, but upper border won't peak so much to become a peak like this. It is like a spike. That won't be there. It is like an arch, it is coming and coming back to the normal. And coming back, see, it is like this. It is like this instead of like this. If it is like this, that means it is definitely peak. I think so in the Seizure, we are going to tell about all those things. It is like an arch and coming back. Lower border is raised, upper border remains to be normal, and it is comes back. That's what Dr. Neha has explained during the crying or movement is there. Other one, high frequency, even in EEG, you can see high frequency. She told very good, excellent. Then about the heartbeat, even if the needle is there, it will pick up very neatly even ECG traces. But one thing you should remember in the artifact, catch. What do you mean by catch? Number 1 is mobile. What is the catch in this is it will be sometimes more than the 5 but less than the 10. This is the catch. What do you mean by that? More than the 5, less than the 10. If you take that background pattern classification, nothing is there more than the 5, less than 10. There is nothing is there. So if like that, more than the 5, less than the 10, but it follows like this. If it is there, that is the one way you can think it is probably an artifact. That is one catch Neha has told, very correct. So one is muscle of mastication, another is high frequency ventilation, another is heart rate, another is movement. If sister is moving because of the urine or something like that, it is like a messy, it will come. But in the machine, in this machine, what it is showing is, even suppose sister wants to change the pamper, sister want to give the medication at the time of seizure, or sister want to pat the baby, or sister is turning the baby, everything she can go to that marker, press that marker and tell this time I have done this. If she will press it, there will be a line will come in that. If line comes in that, what happens? It is easy whether it is an artifact, whether it is an something else. So we are going to show you that in a meanwhile. After the next question, we will show you this. Okay, see, please, can you come here? Can you come here? See this?
Select.
Yeah.
Go to marker.
Marker. 1 minute. Yeah. See, can you people read here? Please, can you people read this? Okay. Seizures, turned care, medication, sleeping, X-ray has taken. Seizure is there. Whether ultrasound done on the brain. Okay, or whatever care means, any paper change. Or in this, just press it. Go to the top, my dear friend. Yeah. See here, exactly on that line, it will tell what we have done. So if this is the one advantages about the CFM OBM machine. So if you go back to the 3 leads, these all advantages are not there. And this is a newer machine because this year it is launched with AI and other things that we are going to tell later. Thank you, Neha. Thank you very much. Over to Prashant.
Yes, sir. Let's see, sir.
Yeah.
Significance of impedance, sir.
Yeah, I think already Dinakar has explained very well. In addition to that, my previous speaker also, Neha, as well as the Monika has already mentioned. Now, this is one of the important factor while we recording aEEG. And this is one of the reason most of the nursing staff find difficult to keep the electrodes in place. Basically, impedance is nothing but it is the electrical activity, a small amount of electrical activity is picked up between the 2 electrodes. And if you see here, this is the right hemisphere or right electrodes, and here this is the left electrodes. And here it is the 0 mark, 10 mark, and 20 mark. And always the impedance is measured in the terms of a ohm. This is nothing but how closer our electrodes are to the skin. And that is how good we can get the tracings of a cortical electrical activity in the tracings. Anything which is near to a 0 is always good. Whereas anything goes beyond 0 or beyond 10 ohms is always signifies is not a good good electrical or good electrode contact with the skin. So as if you want to pick up the artifact against the underground or normal electrical activity or seizure activity, the better we have a good electrode contact with the skin. That's the reason now, earlier we used to use the hydrogel cups, or in between we have used the gold plated cups also, but every time when we use it, maximum the contact of this electrode with the skin is a very short period. That's the reason we now moved into the hypodermic needles. They stays in when we insert it intradermally, they stays for a long period of time, and we feel they are much better compared to the other electrodes what we are using. Now, what could interfere with the impedance? There's so many things can interfere with the impedance. One is, if you see, as and earlier also Dr. Prathap Chandra has mentioned the lot of hair which is there, and the Asian race always has got a good amount of hair compared to the white race, and that is where our impedance can affect, and the electrical activity what we detect in the aEEG could affect. Presence of vernix caseosa, again the skin, the electrodes are not in touch with the skin, or anything which tissue underlying the electrodes is not live, is a dead tissue which could interfere with the electrical activity. So these are the areas where we need to take care. That's the reason we need to take care, separate the hair, and then apply the gel, and then over that add the electrodes. The one more thing Neha has already mentioned, the most of these babies are nursed under the reagent warmer. And this hydrogel over a period of time get dry. And as it get dry, it becomes the activities, what we get, the electrical activities becomes lesser. So the best way to keep this, the electrodes a good contact is put a drop of a water, especially when there's hydrogel is there, and you can get a good conductivity and we can get the good electrical activity also. Now, in the beginning, I mentioned most of the equipments has got the impedance check before we start the recording of the baby's aEEG. And the signal which keeps coming as a green indicates that the electrodes are in good contact. The moment it goes to a red, it means that the electrodes are not in contact with the skin. So it is the responsibility of a nursing personnel who is next to the baby is always the electrodes to be in contact with the skin and always try to get this green signal so that we have a good electrical activity being documented, and that which helps in the interpretations.
Thank you, sir. Thank you.
Yeah.
Dinakar, sir.
Prashant?
Yes, sir.
Yeah.
Yes, sir. Yes.
Prashant, really Leslie has done beautiful work. Impedance, one word. Impedance, one word. It is a resistance. That's what sir has told very clearly. It is a resistance. That's all. If resistance is too high, it is dangerous. It should not be more than 10. So here, in the where raw EEG will come. So here, can you come near, please, if you don't mind? No. Yeah, here. Very good. See here, there are two things. One is raw EEG movement. Another one is impedance. Raw EEG here only down, right, left, right, left. The impedance is 0. Can you see that line? 0. 0. As much as possible, it should be 0. And here it should be green. Here there are, can you come near? Here there are 1, 2, 3, 4. What sir has showed, it is 1, 2, 3, 4 is there. Everything should be in green. That means it is finished. Excellent. Everything is good. So your art, whatever the tracing you will get here, it is good. Number one, what we should remember, what now sir is showing in the screen, it is coming green. So this is the portion where it is coming. I think so. This is my finger. This is my finger where sir is showing. This is the one. Yes, sir. Okay, number one. Then what sir has told in a previous slide, it is a really excellent. Can you go, Prashant, previous slide? Prashant?
Yes, sir.
Yeah,
Yes, sir.
beautiful. But only one thing, sir has explained beautifully. Not next slide. Yeah, but only during the hydrogel. That is the word. What sir is told, it is called hydrogel. What do you mean by sir has told hydrogel? Leslie has told this is the one hydrogel. Because why that word called hydrogel? It is a very good contact like a ECG. Because ECG we use a gel. So ultrasound is a different gel. ECG is a different gel. The same gel they have condensed more, but it is an hydrophilic. Philic means more love. So that is the reason it will keep the water inside this. So it will have more contact with the skin and it attracts the electrical signals to this. That is the reason this is the water we have to apply to this. What sir has told, said that more electrical signal will keep on picking up because water. But if it is what sir was telling, very good one is, I mean previous slides, which one should choose? Hydrogel should be chosen either in a late preterm or term baby. That means it's a bigger head because the distance what it is coming is little, because if it is a preterm, what both the things will come into the contact and electrical shock, the tracing will become an artifact. That is the reason in a preterm what sir has told is very good. It is an gold plated cups. And one more thing, can you give me this? See, can you show this? No, I didn't tell you. See, can you people see this called conductive? That means I don't want anything in between. That is the reason we have taken conductive things, that gel, and applied on the skin. Then we have put the plaster, said that there should not be any problem. That itself is almost fixing it. You people can see. If you want, you can put a plaster. This can be used in a premature baby because it is very small. We can use for a longer baby, like 24, 25, 26, 27 weeker, we can use this. So after 30 weeker, I think so this will do, but many people do use up to 34 weeker, this gold plated. This is one because of decrease the impedance. Suppose edema is there, yes, sir has showed in the video, or long time you need the ECG reading, aEEG reading, that time, and always if this is coming off, this is irritable to the nurse, and whenever you come in the morning, whole night it is showing artifacts, and sister is not managed. That time you try to use, for your benefit and the baby benefit, needles. Number one is edema, or if you want a long time and bigger baby, and if you are not comfortable, sister is not comfortable either with hydrogel or this is better. So this will give a very good contact with the skin. From there, whatever the electrical this thing is there, it is there. Thank you very much, Dr. Leslie, for a detailed description. Thank you, sir.
Thank you, sir.
Okay, over to Prashant.
Yeah, Dr. Kiran.
Hi, can you hear me?
Yes. Over to you, Dr. Kiran.
Okay.
Explain how amplitude EEG works from EEG and about the window reading. Simple mechanical definition of amplitude EEG.
All right.
You,
Okay. Sure. I think first of all, thank you, Prashant, Dr. Dinakar, and Neogurukul for this opportunity. I will not take much of your time. Probably. NNF, yes. And it's been a fantastic session so far, and I'm sure everyone is pretty overloaded with a lot of information going. And my topic again has been covered by Judy and Dinakar and everyone. I'll just say 2 minutes. It sounds that this whole process for the beginners, it might be sounds too complicated, but actually the beauty of it is it's pretty simple. And the machines and these companies have made all the interpretation very easy. So what we need to know, when we put two electrodes, we basically need 2 points for any waveform to get generated. So when you put two electrodes, it creates a signal channel, and then a wave is created. Go to the next slide. Now, if you look at the individual waves, next slide. Yeah. So, interpretation of these individual waves is very difficult. If you start focusing on point-to-point variation, you can't really make sense out of it. And we are neonatologists, we are not neurologists interpreting the EEG, and we don't probably not to try to become one. So basically, these machines are so smart, they modify all the signals by doing filtration, rectification, compression, and slowly they sort of plotted display, which is, it makes it easy for us to understand. And as already mentioned, the 15 seconds of the variation in the voltage is just recorded as a single line. So it is like, if you've looked at the earthquake, the Richter scale, every vibration is recorded as a single line. So similarly, the vibrations or the variations in the electrical activity in the brain is recorded as a single line. Now, once we go to the next. Next slide, please. I think it's taking time to load. So can you see the next slide? Yeah. So basically, what a normal EEG, what neurologists look at is a 12-lead EEG. And for a neonatologist or a layman person, it's always hard to interpret. You can, with the training and of your visual eyes, you can. But, you don't need to have that much details for a bedside examination in the newborn. So that's why we work on 1 to 2 channel or 3 channels. And as you can see, the machine rectified it, processes, and process it and compress it over the time to see a waveform which we have been seeing now last 1 to 2 hours. And then what we just try to do is make an interpretation out of it. So this next slide. So I always tell my juniors, this is like this machine is doing a transformation. Once we don't know before the transformer is formed what exactly function is going to happen, but once we have this transformer, it tells you exactly what is he going to do, what is his hands are like and the legs are like, and what is he going to act. So the aEEG from a raw EEG is a transformation and forming a transformer which is helpful for us. So this machine, what this machine basically does, it just gives a snapshot of what's happening inside the brain. And because it compresses, and this is important slide which Judy has nicely explained, what is called as semi-logarithmic. Basically, we are interested in 0 to 10 voltages, so those voltages are linearly plotted, because any variations in these voltages we need to pick up, we can't afford to miss. But the voltages beyond 10 up to 100, they are basically plotted in a logarithmic way. Just to simplify it, basically when the machine is trained so that it will pick up the smaller variation and the variations within that 1 to 10 voltages, and then it will sort of modify the higher voltages so that it doesn't change the waveform too much, so that it makes this interpretation very easy for us. So that's why all our focus is between this 0 to 5, 0 to 10 up to 25 voltages, and the variation of that will be compressed. And because it is a slow tracing, a 6 centimeter trace is actually for 1 hour. For 1 hour it is plotted only in the within 6 centimeter of a distance. However, so there is a chance you can miss the individual seizures. That's why we still need to look at the individual the voltage activities, and then look at the big picture, which is the amplitude integrated EEG, and they make interpretation out of it. And in the next few slides, you will again go through the different patterns we need to identify. But don't forget to miss out the individual seizures, bearing the artifacts in the mind. So that's all I would like to say. I think this is a fantastic machine. Once you start interpreting and looking at it, it's really easy, and even nurses can interpret it very easily. Thank you.
Thank you, Dr. Kiran. Dr. Dinakar, sir?
Yeah, Prashant? Yeah, Prashant?
Yes, sir. Yes, sir. We can hear you. We can hear you, sir. Go ahead.
Yeah. Can you go back to Dr. Kiran's slides, please? There are two things very important. Can you go back, Kiran's slide, please? Yeah. So I want to tell, I think so Kiran has explained, nothing is more than that, what is there in that EEG. Simple one word. Please be there. No. Okay. Number one. What Kiran has told is that's all. We need 2 leads to make it. See here, I was telling everybody, no, go back, previous slide. Yes. See here, what is the amplitude EEG? Only they will take the EEG, raw EEG, they will take it. After taking the raw EEG, what they will do with the raw EEG? The maximum and minimum during the, whatever the 15, I told you 15 seconds. In that, which is the maximum, which is the minimum. Then which is the maximum, which is the minimum. Like that they will take, they will calculate. Then they will do 3 things. Go to the next slide. Go to the next slide. Okay. So they will do 3 things here. One is, I told you, FRC. So what is FRC means? I think so you should go back, Prashant.
Yes, sir.
Yeah, please. Everybody should remember what you mean by FRC. They will take the raw EEG, then they will do the FRC. What is FRC? Functional residual capacity. It's not that. it is filtering the 15 seconds raw EEG, then they will do the rectification, then they will do the compression, then they will do the filtering, then they will go very slowly and display the signal. That was F, R, C, D. With that, all those things, they will do the amplitude. See, that is amplitude integrated EEG. What is aEEG means? Amplitude integrated EEG. They will take that maximum and minimum, maximum, minimum. They will take, after taking the amplitude, they will do the filtering, rectification, compression, then they will integrate it into the amplitude aEEG. That is the only simple definition what Kiran More beautifully explained. Why I am just repeating? Because many people are new. They should know from where this aEEG will come, how they will compress. And one more thing is, remember, I told you in the screen, can you come to the screen, sir? Yeah. In this screen from here to here, this is 3 hours. Beautifully he has explained. This is 3 hours. In 3 hours, 6 centimeter is 1 hour. Then in that 6 centimeter, 3 centimeter is half an hour. In that 3 centimeter, 1.5 centimeter is 15 minutes. It is divided. Why I am telling is, when the seizure class comes, who is explaining, they will explain more better why the time is very important to differentiate whether it is status epilepticus or how much time baby had a convulsions. That is the reason I am telling you the time here it is 3 hours from here to here. From here to here it is 3 hours. So 1 hour, 2 hour, 3 hour. It is totally 18 centimeter. Each hour is 6 centimeter. That is very important. It is all whatever it is coming, and from here to here, whatever it is flow is there, 15 seconds. That 15 seconds spike. One spike is 15 seconds. This is the one we want to know. And one more thing, whatever the EEG is there, it is compressed between, see, you people can see here, 10, 25, 100, then 5. It's beautiful, but in the EEG, it goes minus 50 to plus 50. Because this is not an exam. Why I am telling is, suppose if the postgraduate or the PGs or the fellows amplitude EEG with hypothermia, anything, at least they should know minus 50 to plus 50. That is microwatts, volts, microvolts. That is compressed here. Thank you very much, sir. Beautiful explanation, sir. Next question, sir.
Thank you, sir. Thank you, sir. Next is for Dr. Monika. Can you explain what is BPC and its classification, and what do you mean by a sleep-wake cycle?
Yeah, Prashant, I think it was very well covered by Judy. I would just like to, re-emphasize on the things which she already covered. And so the patent definitions were given first by Dr. Nakib in 1999, where he had actually given a very simple classification: normal, moderately abnormal, and severely suppressed. So those 3 were very easy to use, but then and the problem with this was that there was sensitivity and specificity was little lower, and inter-observer reliability was a bit less. And then came this 2006 Harrison-Vesta's classification, where it looks like a very broad one and bigger one, but it is actually a more reliable one. And it is giving us like these patterns, which we already talked about. I will talk more on that just to emphasize how to really pick them up. So he classified into continuous normal, discontinuous normal, burst suppression, continuous low, and flat. So only 3 things we have to see when we are describing them. We have to look at the lower margin, and then we have to look at the upper margin, and we have to look at the variability and the sleep-wake cycle, whether it is happening or not. When I'm putting the pointer, can we see it? Prashant, if I'm putting a point, we are able to see it. Yeah.
Yeah, we can.
So what we can see this is the so before we start, we should know that there is something called CFM site and CFM without site. So we should always prefer to have CFM with site, CFM site, not without site, because that gives an enhanced kind of signal display, so that we can actually pick up the interpretation easier, so that we are not missing up and maxing with the that. So that will be due to the the background and the signals what we are coming, what is the gradation between the two. That is what the CFM site is. So now let's talk about the continuous normal voltage. So when we talk about continuous normal voltage, what you can see from here is like these numbers. You can see 5, 10, 25, 50, 100. So these are the numbers which you have to see. And horizontally, you have to see where are the markings more dense. And the lowest part is the lower margin, and the uppermost part is the upper margin. So we have to see according to that. These are the things which we have to see for every kind of a background activity, and then we can interpret easily. So in a normal voltage, what happens is the lower one will be always above 5. So you can see this is 5. So they will be always above 5. And the upper one will be always above 10. So this is 10. So this is always above 10. And the maximum marking you will see, where is the maximum? You can see these are the maximum marking. The maximum marking are generally on 10. So three things: the lower margin is above 5, the upper margin is above 10, and the maximum margin markings are at 10. This is very, very important. Now you will see that this is not going symmetrical band. So some places there is a narrow, no, the previous. Prashant, previous slide, not finished. So some places is narrow and some places you can see wide. Now, why is it happening? This is because of the normal sleep-wake pattern. So what we are calling SWC, what it is. So it is a sleep-wake pattern where when the baby is sleeping, what happens is the lower margin slides down. And so it looks more broader. When the baby is awake, the lower margin slides up. So this is more narrower. So this is awake, this is sleep. Sometimes this this is giving a kind of a sinusoidal kind of a activity. So this is how it looks. And when we have to see that at least in a normal term baby, the sleep wake pattern should come at least 1 in 3 hours. So that is very important. The sinusoidal activity should be coming in 1 in 3 hours. Now, when does this sleep wake pattern is reliable? This is generally, it starts at 28-29 weeks, but it becomes more mature after 32 to 34 weeks. So also for a preterm baby, we can see that if it is maturing enough or not. So this, if absent in a preterm baby, its term is taken as normal. But after 32-34 weeker, and especially for the term, you should have this sinusoidal activity. So what you will see in a continuous normal voltage, lower should be above 5, upper margin should be above 10, maximum marking should be at 10, and there should be a sleep wake pattern where during sleep it widens and may go below 5, and during the wake it has to be small. So when you see the width, the bandwidth variability is quite limited, and it is not going beyond 15. So it is between 5 to 15. And the lower margin you can see is wavy. So this is absolutely normal. Now let's go to second slide. So the second slide is discontinuous normal voltage. Now what is this discontinuous? You can see there is what is happening. What did we see in the last one? It doesn't like the same. Now what has happened, if always start from here. So look at the lower margin, look at the upper margin, look at where are the maximum markings and see the variability and the sinusoidal pattern. So first look at the lower margin. What are we seeing? The lower margin is going below 5, right? The upper margin is still above 10, and the maximum now markings are around 5. They are not around 10. So this is what is different from the continuous normal voltage. So, and you cannot see that sinusoidal pattern. It is almost going in the same way. So that sinusoidal pattern is lost. And what about the width? Now, because the lower margin has gone down to 5, the width is quite more, and it is generally up to 25. So this is something which is different from the normal pattern. Now, this width, which you are seeing as bigger, can also get widened in other conditions, like when in the normal continuous normal voltage, when we look at only the sleep part, as we said, the lower margin goes lower, so the width may be high, bigger in that, but that will be only for some time. It will not remain the same width. So this is how you have to differentiate. And sometimes when someone is manipulating the baby, what happens, the upper margin may go up and then the width will look bigger like this, but then it is not remaining like that. And how you will differentiate? The lower margin will be less than 5, so in discontinuous, and in that the lower margin will be still above 5. So we should differentiate, because it will not always come like that. Some interference may occur, some other things may occur. So each time we have to see whether those are the causes or there is really a problem with the kind of wave. So what you can see, other thing is that lower margin variability is present, so it is like more wavy, but the sinusoidal pattern is absent. So these are the ways where you will say it is a discontinuous normal voltage. To summarize again, how do you say it is discontinuous normal voltage? The lower margin goes below 5, the upper margin goes still above 10, maximum marking are at 5, the sinusoidal pattern is not there anymore, the sleep wave pattern is absent, the width is 25, and the lower margin is wavy. Next. Next slide, Prashant. Yeah, so burst suppression pattern. Now, whenever you see this burst suppression pattern, please, it is very, very bad, and it is one of the bad prognosticating sign for the baby, and we don't like to see this burst suppression pattern. However, as Neha had described, that these kind of pattern may also, sometimes you may see when the baby is on a high frequency ventilator. So you should know how to be sure it's a burst suppression pattern. So as the name is telling, there is a burst and there is a suppression. So it looks like a, how it reminds and looks like what? It looks like a female comb. That's how you can see it. So you see the lower margin again. Don't follow. Don't break the rule. Always follow the rule. See the lower margin. See the upper margin. See where there is the maximum marking. See whether there is a variability. See whether sleep-wake cycle is there or not. So let's go one by one. The lower margin is below 5. You can see this, and the upper margin is going beyond, touching up to 100. So there is a burst and then there is a suppression. So the distance between the burst suppression would depend on how much time the burst is staying, and then it is coming back to the suppression. So this is the baseline, less than 5, and the burst is going beyond 100. So what do you see? Do you see any sinusoidal rhythm? No. Do we see any sleep-wake pattern? No. So we are not seeing that. And the bandwidth variability now is very much high, much beyond 25. See how bandwidth variability too much it is. And as the interval is increasing, the trace takes the shape of a fine tooth comb, as I said, the female comb appearance, and it is a very, very bad sign. So how do you see burst suppression? The lower margin is less than 5, the upper margin goes beyond 100, the width variability is more than 25, there is no sleep-wake pattern, and the lower margin variability is absent. And you will see it like a flat. The lower margin is almost a flat, not going up or down. It is flat. And it is a very, 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 very bad sign. Next. Then the continuous low voltage. So now what we said, the normal voltage should be, lower margin should be more than 5 and the upper margin should be more than 10. Supposing now this is not happening and we are having low voltage which is continuous. So what happens here now? The lower margin goes below 5. As I said, don't break the rule. Go one by one. So we will see first the lower margin where it is. It is below 5. So the lower margin is below 5. Where is your upper margin? The upper margin is also below 10. And where is your maximum markings? They are around 5 or below. So the lower margin is less than 5. The upper margin has also shifted below 10, and that's why the width is reduced. Now, how much it is? The bandwidth has reduced to only 4 to 8. Yeah. And what else? Do we see this, that sinusoidal pattern? Do we see the sleep-wake cycle? No. It is like a low voltage throughout. And the lower margin, again, the variability is absent. It is almost like a flat line which is coming near to 4 or 3, like that. So this is also a very, very bad kind of a sign when you see in a baby who is already suffering from some problem. And sometimes this burst suppression pattern can look like a continuous low voltage. And what you have to see that the upper margin in that is should be more than 100 when we say it is a burst suppression. Next slide. And this one is looking like a men's comb. You can see the men's comb is smaller one which they are keeping in the pocket. The men's comb is the continuous low voltage and the female comb is like a burst suppression. Then this is the worst thing I can see, in a baby. If I see a total flat trace, I am really not happy with the baby and the outcome are not going to be good. And what is this flat trace? Again, follow the rule, see the lower margin. The lower margin is much below 5, it is around 1, going up to 0, I think. So it is like 1 to 2. And where is the, it is less than, it's going 1. And the upper margin where it is around 2 to 3. So the bandwidth is around 1 to 2. You can see, so this is very bad. So you can see here, the upper margin is below 5, the lower margin is below 5, but much below 5, between 1 to 2. And hence the bandwidth is only 1 to 2. And you cannot see any kind of sleep-wake cycle, no sinusoidal activity at all. And there is the lower margin again is totally flat and not at all going up and down, no waviness is there. And to see this means your electrical activity of the brain is not there. However, when we say so, we cannot, seeing this, tell that baby is brain dead. Mind it, no? Don't take it as a brain, to define the baby as brain dead and discontinue the treatment. To define the baby brain dead, you need to do CEEG and cannot rely on aEEG to say that baby brain dead. Only thing what you can see from here is it's a flat trace, its electrical activity of the brain is very, very low. So the sinusoidal pattern which we had already talked about, that this is how it looks like. So this is the sleeping time where the lower margin has gone below lower, and it is, some of them may even go below 5, but that is transient. Don't say that because it has gone below 5 it is abnormal. It will go up again, and it will be more than 5 when the baby is awake, and you will see this sinusoidal pattern. You can see the sinusoids, how it goes. The same way the this is going, sleep, awake, sleep, awake. So must look at the lower margin, and you see how nicely it is variable also. The lower margin is not like straight line, unlike the other ones. So this is the normal sleep cycle, and as we said, it's there 1 in 3 hours. I hope I explained it, and we will be able to pick up the abnormalities very well. Thank you.
Thank you, Dr. Monika.
Dr. Monika. Yeah, thank you very much, Prashant. Yeah, it's very nice elaborated this thing. I think so. It's echoing, Prashant. I think so. It's echoing, Prashant. Now it's fine. Okay. See, everything is over. What she was telling, 5 things. Remember, just make yourself burst suppression pattern in the center. Just above the burst suppression pattern, 2 things: continuous voltage, discontinuous voltage. Easy to remember BPC. Background pattern classification. Center one is burst suppression pattern. Just above that, one is continuous, another discontinuous. Below the burst suppression pattern, continuous low voltage and flat. How to remember that? Continuous low voltage less than 5, less than 5. Upper margin, lower margin. Finished. Less than 5, less than 5. Continuous low voltage. Continuous low voltage. Less than 5, just at the less than 5 and at 10. Then come to the burst. One thing easy to remember, burst suppression pattern she told. It's a lady's comb because big tooth. Lady's comb. But if it comes to the discontinuous, continuous low voltage, it is a male's comb. Keep it in the pocket because it is in the burst suppression pattern, it goes up to the 100. That is the reason big because they have a big base, big teeth comb. That is called a burst suppression pattern female comb. It goes to the 100. Continuous low voltage out to, because usually confusion in between. It's a low voltage up to 25, small male pocket comb. That is what she wants to tell. It's very easy to remember. Over to the next question, Dr. Prathap.
Yeah, Dr. Prathap. Dr. Prathap?
Yes, I'm here.
Yeah. The next question is how CFF machine can detect seizure activity and clinical application in superficial versus deep brain pathology with amplitude EEG machine.
I think, Prashant, keep going on the slides because it's too late now anyway. And what I would suggest is how it detects is not important. At the end of the day, when we have these electrodes which are placed on the the parietal and the central areas, then majority of your neonatal seizures happen in those areas. And whether it is deep-seated or superficial, when you look at the pathophysiology of birth asphyxia, which is one of the most common reasons why anybody would use a amplitude EEG, in those circumstances, I would say majority of your seizure, almost 90% of them, will be detected. If you have a brain abnormality like polymicrogyria, schizencephaly, any of these areas where if it is deep rooted or deep seated, it might be difficult for the amplitude EEG to pick up. But a lot of our new machines have got EEG as well as amplitude EEG to assist. Now, when you look at the seizures, it can be just one-off seizures. Number 2, it can be within the 30 minutes the seizure will last. Number 3, it can be more than 30 minutes. Let us just concentrate. What happens if there's a seizure activity? All your brain cells are extremely excitable, and then when they're excitable, their electrical activity is very, very high. And therefore, if you look at this, I don't know whether my pointer is visible, but when you look at this, the baseline of all these waves will become higher. Baseline itself is higher, and then the higher line, the higher amplitude of that is even higher. It can go to more than 25, sometimes more than 50 as well, right? I would say it forms a shape of a dome, or if you have a temple, if you believe in Hinduism, it's a temple. The dome of the temple, it resembles the shape of the temple. So then, if lot of people said, one activity is recorded in about 5 to 6 centimeters of your screen. So if 5 to 6, if the activity is more than 3 centimeters, and if all your baseline is getting above it, then I would say it is status epilepticus. If there is one-off seizure and then it gets better, then it's great. Then on the other hand, if you have got a seizure, you would have treated with anti-epileptic, then the seizure control is better, and it's come back to the normal baseline with a normal sleep-wake cycle. I call it as, it's like you just observe this: sleep, wake, sleep, wake, sleep, wake. This kind of a cycle, if it comes back to that, then there's nothing to fear. But on the other hand, if there are too many seizure activities coinciding too many times within that 6 centimeter of the period, you're thinking of status epilepticus. When you have status epilepticus, sometimes you would have given anti-epileptics in the first seizure itself. Say, for example, phenobarbital. That's our favorite drug. Just because it should not impede with any of these, in especially treating with HIE and cooling babies, we have selected the anti-epilepticus levetiracetam because it doesn't affect these waves. So if you have given, say, for example, levetiracetam, then you have given phenobarbital, then you have given phenytoin, then what happens is, clinically, if you look at the baby is completely flat. It is completely suppressed. You will, anybody just looking at the baby will say, okay, moderate to severe HIE, the baby is undergoing cooling, nothing is happening. But on this, you cannot lie. On this, you will still see status epilepticus going on. Okay. I don't think I have the privilege of showing this with my arrow. Prashant, you can just direct the arrow where the complete baseline is lifted. Okay. And also the top line is also lifted. Then it comes back, then it forms the shape of a dome. Always remember the temple, the dome of the temple. This is how the seizure activity is detected. If it is lasting for such a long period of time, about 6 centimeters is about 1 hour of your recording. Then you also look at the corresponding EEG, which is well documented in the new machines like the Olympus and all that. So if you look at it, it should form real spikes. We have looked at artifacts by Dr. Neha and all. At the end of the day, this should depict seizure activity. This slide, there is no need for any neurologist. This is where we are talking about amplitude EEG being employed in India, where there are not many experts available, and then the nurses are available all the time next to the baby. Maybe your neonatologist is not available. All I want is a snapshot of this figure to say, oh my God, this baby has got status epilepticus. The whole screen probably corresponds to about 3 hours of the recording. I would have appreciated if the nurse send me the first first hour of the recording, and then I would start, treating this. See, as we go along, COVID is becoming popular everywhere, all over the country. Even neonatologists, pediatricians are not available. Then if I have an amplitude EEG recording this in my HIE baby who's undergoing cooling, where there are only 3 or 4 nurses available for the whole unit. She sends me a snapshot of this every 20 to 30 minutes. I know what I'm dealing with. And at the end of the day, whether I give levetiracetam first, I will see whether it is suppressing the seizures or not, whether it's coming down to the baseline or not. Next, give phenobarbital, give phenytoin, then go for midazolam infusion. However it is, we have to bring it back to the baseline, and then uncoupling, which happens after the anti-epileptic medications, we should see that. Sometimes clinically you don't see that, but subclinically it is still there. There are a lot of evidence which suggests subclinical seizures itself is not good for the developing brain. So that itself can result in outcome which is not good. So in this slide, it is shown that, see, the waves are continuously up. It's unremitting, more than 30 minutes. How do I know more than 30 minutes? Every 6 centimeters of your screen will correspond to 1 hour. Imagine this baby is having continuous seizures. Couple of points clinically. If your seizure is not being controlled, that suggests it's a very, very severe HIE, number 1, or you're dealing with a very severe neurometabolic condition because of inborn errors of metabolism. For example, urocycle defect. For example, pyridoxine deficiency. Your seizures is not controlled at all after giving so many anti-epileptics. Then, on the other hand, you're looking at the EEG as well. EEG is also showing quite a lot of spikes every single time, right? There is a clinical implication, and there is a the brain wave implications as well. When the brain wave implications are not good, you're still finding a cause. You're still finding a cause. You're still finding a reason for what it is happening for. I think probably in the next 1 or 2 sessions, we'll be discussing more about that. Thanks, Prashant.
Thank you, Dr. Prathap. Yeah, I think most of the things are covered, Dr. Dinakar, sir.
Yeah, very nicely explained, Prathap. Very nicely explained. We'll go to the next slide. Jafar, are you there, sir?
Hi, sir.
Yeah.
Yes, sir.
Sir, over to you, sir.
Sir, CFM
this is the last question. This is the last question.
Yeah.
And beautifully, Jafar, please explain. Really, is it worth? Why it is worth in different disease and other things, and about the machine? Please, sir, over to you.
Okay. So cerebral function monitor we have in our unit. So our first indication to apply or to use this machine is for hypoxic ischemic encephalopathy. So the moment baby comes to our unit, we apply the machine. So at least we know the severity of hypoxic ischemic encephalopathy, whether it is moderate or whether it is severe or severe grade of encephalopathy. During cooling, we can use this machine for detection of any seizures, clinical or subclinical, so that we can control the seizure, whether if it is subclinical. Then we can see the therapeutic response. Whereas baby who is having moderate encephalopathy or severe encephalopathy, if we continue the EEG for next 3 or 4 days, so we can detect any improvement or deterioration. Suppose the baby who is coming on day 1 is having suppose some cerebral dysfunction on day 3 or day 4, the baby who is having flat, or we can say that burst suppression pattern, it means that that baby is already deteriorated so much in next 3 days. Or suppose a baby who is having discontinuous pattern, and on day 4 the baby who is having appearance of sleep wave cycle, it means there is a improvement in the encephalopathy. So we use for monitoring of clinical seizures or any subclinical seizure, for improvement or for any deterioration. And even we can explain the prognosis, whether if we prognosticate the parents based on the EEG, at least if the EEG which is having flat pattern or burst suppression pattern, and baby who is severe having also ventilated and some other medicine, so this baby, we can prognosticate that having very bad prognosis. So we can uh, uh, convince the parents whether they want to continue or they want to discontinue the babies, because such a bad aspected baby may have poor outcome. So this is how we can prognosticate based on aEEG. Other additional application we can use when baby who is having some neurometabolic like IEM related encephalopathy, like metabolic disorders, baby who is having neonatal abstinence syndrome, or baby who is ventilated. Other thing, we can monitor the brain when the baby who is very sick. So at least we can prognosticate, or we can do some more monitoring the baby who is having asphyxia, hypoxia, sepsis, or meconium aspiration syndrome, and some other cardiac malformation. So this is how we can use this machine in many other neurometabolic condition as well as cardiac condition, apart from this hypoxic ischemic encephalopathy. Next. So in our unit we have the same machine what you have shown in here in Natus OBM. This is a good machine which is having good touch screen machine, which is around 17-inch monitor, good display of all the waves, and along with two pattern detection software. Then seizure detection software is there. We can having a good gray scale where we can distinguish all the waves distinctly, and it is having some like CFM
Prashant,
side.
next slide.
Along with that, we can have more clear picture of the patterns. So this is a good machine which is having presentation of aEEG along with EEG also. So simultaneously there are two waveform running in this machine. So we can have that real time uh, waves on
Prashant, next
EEG
slide.
also along with this. Okay. Next. So this is having enhanced signal detection, and there is a CFM side which is showing clear picture of the other patterns. So
Next
this is
slide.
a yeah. So this is how that CFM side have clear picture of pattern. Suppose this above picture is without CFM side, which is having lot of blurred vision on the background, and if we apply the CFM side, there is a very clear image which is there are so many artifact has been removed, and now it is showing the clear bus suppression pattern in this. Next.
Prashant, next slide.
Yeah. So this is a good machine which can evaluate both EEG as well as EEG continuously, so that we can detect EEG also along with aEEG if we have doubt in any of the events. Okay. So this is the one cutting edge technology which we can have in our unit, so that we can monitor the baby's brain along with other monitoring of the cardiorespiratory system. Yeah.
Yeah. Sir, thank you very much, sir.
This,
Yeah, thank you very much,
thank you.
Jafar. And really, this is the one artificial intelligence I was telling about the BPC pattern. Can you tell me what is it? Yeah, can you tell me?
So as soon as you click here, the BPC will get activated. Just click it here. Then all the indications are here.
And tell me about the colors.
Yeah, so it's the green color, light greenish color will be the burst separation. Blue color is your flat trace, whereas orange color will mark your seizures. And light dark orange is your seizures, light orange is your continuous, and yellow is your discontinuous.
So this is one advantage. Machine itself will tell you in case if we don't have time, our sister doesn't know, if our education to the sisters is not enough. It is artificial intelligence. It will only detect and tell us. Number one, it will only detect impedance is not correct. It will only detect where is the problem. So sister can press. And one more thing is, this is having more security. That is most important. When you are traveling in your car, you can open your laptop. So you can connect this CFM machine to your laptop, and wherever you go, you can watch the baby, what is happened over the night or day or now. So this is one advantage, it is secured. Not only that, and it can be connected to the central nursing station or monitor. And really, it is a very nice machine. I'm not talking about the machine. I'm telling about the OBM CFM machine, really good. And next class on 29, our next class, definitely Judy Moray will be talking about all the diseases, how CO2 or O2. If O2 is very low, what happens? CO2 is very high, what happens? How to detect? Like congenital heart problems, number one. Second, what happens to this thing? So cardiac problems, shock, hypotension, then normal surgical problems, not only other things. So where and all where we can use aEEG, everything Judy Moray is going to talk, number one. Then on fifth, advanced aEEG, it is very essential. Many people, even myself, I doesn't know. So we will attend all the classes. We will get the knowledge.